دوستان عزیز، با درود و خیر مقدم به تمامی شما عزیزان، سروران گرامی، فرهیختگان اهل علم و تحقیقات. من دکتر محمد شکوه امیری هستم که برنامه اولین کنفرانس علمی سالیانه پاما رو به صورت ویرچوال مجازی برگزار می‌کنیم. امروز یک شنبه 14 سپتامبر 2025 ساعت 12 به وقت شرق آمریکا می باشد که برنامه را شروع می‌کنیم. در ابتدا به خوش آمدگویی از طرف آقای دکتر حسین شکوه امیری پرزیدنت پاما گوش می دهیم و بعد به خوش آمدگویی از طرف دکتر سعیدی به عنوان وایس پرزیدنت پاما. آقای دکتر شکوه امیری بفرمایید.
I would like to welcome the members of the PAMA and also our friends from all over the world, especially from Iran, who are participating in this annual scientific meeting. And this is the first scientific meeting that PAMA is holding. Yesterday, we had a very successful meeting, and today we have another one. And we have a great, well-known internationally keynote speaker, which I have been honored to be his student, and I will introduce him later on after Dr. Saidi gives the housekeeping messages for today's meeting. I hope that you have enjoyed yesterday's meeting and continue to enjoy it today and be with us to the end of the meeting. Thank you so much. Dr. Saidi, please go ahead.
Thank you. I would like to welcome again all of you to the second day of first annual meeting of PAMA. I think I will also welcome our keynote speaker, Professor Rastegar. Yesterday, we have a very lively and interactive session. I hope that today is going to be the same thing. I would like to also again remind everyone that we will provide 8 hours of CME through International College of Surgeons. If you're interested to obtain these CMEs, please send us an email through info@pama.ngo that we can send you the link. I also would remind everybody that we're going to award 3 Young Investigator Awards based on all presentations that was done today and also yesterday. We have today, again, we have a very good program with a mix of presenters from junior to senior presenters, and I hope that we have a good meeting. Please unmute your microphones if you want to just mute your microphone for now, that we can listen clearly to the presenters. And I also encourage everybody to stick to the time. We have each presenters have 12 minutes to present and then 3 minutes of question and answer. I hope that you're going to have a very good meeting today. Thank you.
جناب دکتر رستگار برنامه شما شروع میشه. بفرمایید دکتر شکوه امیری، ایشون رو معرفی بفرمایید.
Yes. It is indeed my honor and privilege to present Professor Emeritus of Medicine and Nephrology at Yale University, Professor Asghar Rastegar. Professor Rastegar, I had the honor of being his student, and I'm really happy that he is our keynote speaker today, and he is one of our honorary members. Professor Rastegar spent his early life in Shiraz, went to the best high school in Shiraz, which was Namazi High School, and then moved to Tehran for the last 2 years of his high school to the best high school of Iran, Al-Bors. Then he moved to United States and got his medical degree from Wisconsin University and moved to Pennsylvania for his residency and fellowship in internal medicine and nephrology. Then moved to Iran. There I can tell you that, of course, Pahlavi University was a very good university and we had excellent professors, but coming of Dr. Rastegar and Dr. Ismail Begi, Dr. Molavi, and few others made a huge difference that everybody observed it immediately, that what a high caliber professors came to Iran and they changed the environment so much that first of all, people would love to be in medicine in Pahlavi University, and also we were eager to listen to their lectures. One of the testimony that I can tell you that this is my own history, that when I finished medical school and I had to leave the country and came out, you cannot believe it, that I did not feel a little bit of a difference between where I got trained in Iran, in Pahlavi University, and what I was facing in the Western country. It was the same or even better. We had both a very good curriculum, and also practically we were very ahead, so we shined. All our classmates that came to Western country, they shined, and thanks to people like Professor Rastegar, whom I am honored to be his student. Professor Rastegar is the founding director of the Office of Global Health, which shows his passion for not only the Iranian, but for the whole world. As a physician, he's exemplified the nature of a physician who just was a patriot while he was, I think, 10 years in Iran, 5 years before revolution and 5 years after revolution. I'm sure, like me, when we found that we cannot do anything more in Iran, we cannot help it, we decided to come to outside, because now we are doing what we can do as Iranian to glorify the name of Iran and also help other people of the Iran. It's a real pleasure that to have Dr. Rastegar today. Please welcome him. Go ahead and please start your talk.
Thank you very much, Dr. Shukor Amiri, and thank you, Dr. Saidi. I really appreciate and I'm honored to have been invited to join you today. My talk is on building human capacity for health. Although I'm a nephrologist and practice nephrology right in that area, my passion has always been in building capacity for health. But I want to tell you my story of how this began and where we ended up. As you heard, I was born in Shiraz. I stayed there for 15 years. Although I left Shiraz at a young age, Shiraz never left me. I love the city. It was the place where I gained my political and my intellectual foundation. It's also a city that not only Islamic Iran, but also Islamic Iran with wonderful mosques, as all of you know, the great poets and all of that. So my love for the city was a love that remained with me even today. I still consider myself to be a Shirazi. I went to the United States for 14 years and then was recruited to go back because I knew I would always go back. I had never in my life, despite getting married in the United States, having children, having been offered jobs at Penn, and then in Tehran, I wanted to go back to my hometown, to Shiraz. And I went to Pahlavi University at a time that it had already switched from Shiraz University to Pahlavi University, from a European style to an American style university, with English being the main language of instruction. So it was an easy landing, and I landed in a department that was already, while small, really was full of individuals who were outstanding, both teachers and clinicians. And I want to talk about two of them. One is Dr. Khosrow Nasr, who passed away about 3 years ago. Khosrow was a Yale College graduate, Columbia of Chicago, trained, he went to Iran. When I met him, he was the chair of Department of Medicine. and he's the one who recruited me back to Shiraz. He met and worked with giants of medicine in this country. Khosrow is among them. He was one of the most creative and most forward-looking individuals I've ever met. He worked through consensus, built a department, and brought Dr. Esmailbegi. Faramaz was a Hopkins graduate with MD, PhD from UCSF in molecular biology, then trained at Hopkins in hematology, and he went to Shiraz a year before I did. But for about a year before I went back to Iran while I was on the faculty at Penn and chief resident in medicine, I actually had conversation with both of them about my job and what I had in mind when I wanted to come back to Shiraz and work with them. And what I had in mind was to develop a model to deal with brain drain, which was a major problem at Pahlavi University, and also other major universities in Iran. The challenge was that we were losing the best graduates abroad. We had inadequate number of qualified faculty. So response short term was to recruit and train with support from institutions abroad, the best graduates as future faculty. Long-term goal, institutional capacity, so that training could be done in Iran, research could be done in Iran, and would be independent in really recruiting and then training future faculty, not only for Shiraz, but for other medical schools. So we developed a collaborative program with major institutions abroad. The focus was to strengthen the residency program and train residents and recognize them as future faculty and make sure they are mentored to develop that. Our collaboration developed with Penn, where I had trained, with Yale, UCSF, Columbia, University College London, and St. Thomas Hospital in London. So those are institutions that we recruited to accept our residents, and actually they accepted our training in Shiraz as part of their training abroad. And then we recruited outstanding faculty from these institutions to come to Iran to join us for periods as short as 3 months, as long as a year and a half, actually. So how the program functioned, we selected resident and future faculty, and it was in the number of years they had to spend in Shiraz increased year to 4 years. In internal medicine was being done in Shiraz. They would then go abroad for fellowship only. So by the 4th year, that's where the program was. And then we began developing fellowship in Shiraz. Now, the program, by all criteria, while short because of revolution, was successful. It made your key to success was not the structure I just explained, but the fact that we recognize that our residents had the ability to become independent, lifelong learners. We wanted them to come to believe that, to know that they're as good as anyone around the world. This is to work with residents coming from abroad, with faculty coming from abroad, to begin to recognize that the environment in which they're being trained was challenging them, was supportive, and they could have a relationship with the faculty that was horizontal, never vertical, and in that way to begin to believe in their own capacity as independent thinker and lifelong learner. That was the goal of changing the environment in Shiraz. The 6-year outcome was that we began to retain the best graduates in Shiraz. We also were successful in placing outstanding candidates in both US and began to increase the number of highly qualified faculty in Shiraz. Now I have to admit that the work was not done by me. It was done by all the faculty in the Department of Medicine and other departments, because the evolution was happening actually at all events. I also spent 2 years as vice dean to look at the curriculum medical school, and that was also evolving during the same time. Now, revolution happened. It also happened in Shiraz. And there was a major break, obviously, with past during that time. In 1980, the Cultural Revolution happened. By the way, after the revolution, I have to admit, I was elected by the students, residents, faculty, and workers in the medical school to run the Shuraya Danishkade, to run the medical school at probably the most turbulent time. I stayed in that job for a year, then became chair of medicine, where I stayed for 2 years, but then other things happened. The university began to go through what's called cleansing, Paksazi, and then there were attacks on the students and the faculty everywhere, including Shiraz. Pahlavi was under a different level of pressure than all other medical schools because of its history and its structure. I was on the executive council, then several faculties were dismissed from medical school. There were several colleagues who were arrested. I was finally arrested in December of 1981, and I was dismissed from medical school after spending a short time as guest of the government. I had to move to Tehran and join a different structure, private practice. In Shiraz, we were full-time. We had no private practice. In Tehran, the only way you could live was to have private practice. I tried that for a year and a half, but really missed teaching. And then many other things were happening around me, including several of my very, very close friends who were arrested around that time. So I ended up leaving Iran in 1982. I ended up coming to Yale on sabbatical, then being recruited in 1985 as a full-time faculty. I became chair of medicine at Berserin VA, running a department which was a part of the faculty at Yale for about 8.5 years. But during this time, while I was chairing a department, was a full-time faculty at Yale, was promoted to become professor at Yale in 1988, I was always struck by the question on what about the experience in Iran, what else in the world? And the experience I had gained in Iran was this: the collaboration between institutions in North, in Western countries, and global South should focus on strengthening the existing institutions in global South through building human capacity locally. So it became my belief, having the experience in Iran, that the only way you could have major impact long-term is to increase human capacity in the local institution with the support from abroad, but make sure that the individuals are local, they know the problem, they can have the solution, you don't have the solution, but you have resources in terms of knowledge and in terms of money to help them do that. And I was struck by this question. And then an event happened that I ended up in Russia. I had to do with the fact that USAID provided a grant to study Russian medical education. I was always fascinated by Russia, its music, its literature, and Iran being a neighbor historically, we were connected. So I ended up going to Russia, and I was assigned to an area around the Ural Mountains, to 3 cities, Kazan, Chelyabinsk, Ekaterina. I traveled there, it was in 1993, Russia just opened up. I was in Russia. I was also struck by the backwardness in medical education. The newest book in the library was a 1963 book that I could find. So there was a place with First World history of military exploration, physics, mathematics, all of that, and really backward in biosciences and medical education. So we tried to develop a relationship, and the only medical school that accepted us to do that because of the forward-looking dean was in Kazan. So a colleague of mine, Dr. Sadiq, who actually was a graduate of Shiraz, was my resident, was my chief resident, then a faculty, had come to Yale, was now my associate at Yale, also went to Russia, And through his effort, and I have to really give credit to Majid, we began a project which has stayed at Yale from 1996 to 2014. We started run by Yale Kazan State Medical University to improve capacity building by bringing their young faculty and their fellows to Yale for further training, sending them back over time to populate that school and to help develop a modern medical university. That was a city that was half Tatar, half Russian, and an area that had long-term relationship with Iran. So when we arrived there, it was not a foreign country to us. We fell in love with Kazan, fell in love with people who were working there, and the people that we began to know and develop relationship with. So during the Yale Kazan State Medical University, these are the numbers that we developed, that we brought about 41 individuals at different levels to Yale, trained in different areas, be it ophthalmology, be it nephrology, and they all went back with the exception of one faculty who remained in the US. And they joined the faculty, they joined Academy of Science in Kazan, and they had a major impact. By the time that this slide was made in 2014, 3 head of department were trained at Yale. There were 7 senior faculty trained at Yale. 2 were clinical leaders in the hospital. 3 were junior faculty, and 1 was a PhD student who was still working on becoming a PhD faculty member. So that was the experience with Kazan. So they were, by 2014, when Majid left Yale to develop his own program, and I will talk about that later, the Kazan Majid to his own use. And this is what happened otherwise, which is that Kazan became a center for medical students coming from Middle East, from India, learning, being taught in English by faculty trained at Yale for the first 3 years, learning Russian during the same time, and finishing medical school in Kazan. And these are the number of the individuals who actually began going to Kazan. And Kazan was recognized in Russia as the 3rd best medical school after the one in St. Petersburg and the one in Moscow. Kazan became well known around because of what happened during that 20 years of relationship with them. So 2 questions comes at this point. Why focus on human capacity building? Why do that? And then why did we move to Africa? Why did Majid decide to move to Africa? Here is just a little bit of background. Human life expectancy until the beginning of 20th century, 1900, was about 31 years old. That's all over the world, because of mostly death in children before the age of 5. Then suddenly there was a rapid rise in human longevity of 65 over 1 century. It doubled. It had to do an income, but at any given income, if you take any of the income at $5,000, for example, as you move up decade to decade, the human life expectancy also increases. So it's more than the improvement in poverty. Half of it has to do with better living standard, but the other half has to do with knowledge, technology, and evidence, be it in behavior, be it in health policy. If you look at, for example, at the United States and Cuba, and you look at the number of children mortality, it correlates with the number of healthcare workers. Cuba is a very poor country. US is a very rich country, but they have exactly the same mortality children because of the fact that the same number of healthcare workers. And here is Uganda, where we ended up, having some of the highest infant mortality in the world at that time. And here is the relationship between the number of healthcare workers shown here, and the improvement in health. The worst being in sub-Saharan Africa, with the lowest number of health. It improves until 5 to 3 healthcare workers per thousand, and this is where we are. This is the Middle East. But it doesn't improve if you increase further. So there is a sweet spot that you want to reach to improve health of the population. This is what's happening in Africa. During colonial time, there were almost no medical school in Africa. These are the numbers in sub-Saharan Africa. Post-colonial, they began building new medical schools, as you can see. These are the numbers of different types of medical schools that goes on. So we decided to go to Uganda. And again, it really was Majid Sadiq, who had worked in Uganda for 2 years by that time. Majid is an infectious disease in HIV, had begun working in Uganda, and he convinced me to go to Africa to develop a new program in Uganda focused on human capacity building. And here is the program that we developed in 2006 and continues to even today. This program continues. Mission was to create a mutually beneficial relationship with goal of improving quality of healthcare in Uganda, but also at Yale, actually. The process was to focus on education with the belief that patient care will improve, resources are strengthened or empowered to seek better healthcare. The values that we had was focused on equity to achieve mutual benefit. So it was a bilateral relationship. And the structure was developed, had a bilateral leadership. Majid and this young lady were co-leader of this program. Dr. Harriet Myanja was chair of medicine. And then it was bilateral in education, that Yale students and residents and faculty would go to Uganda, and from Uganda, faculty and students and residents would come to Yale. So the key project was training of Uganda faculty in non-communicable disease, because they were doing very well in training in infectious disease. We developed an Office of Postgraduate Education. It was funded for the last 20 years, about $50,000 a year grant provided to them to do that. And then we developed a high quality training for US-based doctors to go to Uganda to learn about global health. And then develop research centers that would be a collaboration between Yale faculty and Ugandan faculty. These are some of the numbers. From Makerere, 28 faculty came to Yale. It's up now 36 now. 39 medical students came to Yale. We have 2 nurse educators. From Yale to Makerere, they went to Makerere, and 69 residents went to Makerere, and 46 students in different areas, in public health, nursing, PA, and 2 medical librarians went during that time. A colleague of mine, Dr. Jeremy Schwartz, associate professor at Yale, developed what is called Uganda Initiative in Non-Communicable Disease. This is a combined leadership program now supported by NIH to train people in non-communicable disease, which is now becoming a major issue in sub-Saharan Africa. Diabetes, hypertension, stroke, heart failure, all of those are reality. Obesity is reality now in sub-Saharan Africa. This has been going on for the last 10 years and has been quite successful in projects that they are doing. We were then invited to go to Rwanda. Now, Rwanda is where a major genocide happened in 1993. These are some of the pictures of 1 million people being killed in 90 days. By the time that we were invited, it was a stable country, centrally run, a semi-dictatorship, but very well. And they wanted Yale to do the same as we had done in Uganda. By the time we began that, we developed a program that involved 10 medical schools, but the goal they had was much larger. 6 schools of nursing, 1 school of public health, that was Yale, 2 schools of dentistry, to really rebuild the whole infrastructure of education in Rwanda. This began in 2011, was funded for 7 years at a budget of about $30 million a year. And during that time, this is what happened, that we developed residency program, not we, all the group that were involved in different areas, be it in emergency medicine, anesthesiology, all of those are new programs developed in Uganda. And we began expanding the ones that they already have, internal medicine, pediatric, OBGYN, and surgery. These are all new programs that were developed during that 7 years. We trained 309 specialists during that 7 years, 257 dental surgeries, 150 management. These are the number of nurse diplomas, 2,500, nurse with BS degree, midwives, etc. Those are all trained. So about 5,000 individuals went through the program in the 7 years that was funded, Yale being one of the participants with multiple medical schools all coming. The difference here was that the training of specialists were done in Rwanda. They did not come to Yale. They did not go to Harvard. We sent faculty from Yale, from Harvard, from Johns Hopkins, from other places to Rwanda, staying for a year each to train people locally, become twin with somebody, train that individual in their own area of expertise. This was a different model than the model that we had in Uganda. Then we were invited to go to Liberia. Liberia is a post-conflict country, war for about 20 years. So it really was destroyed by the time that we got there. So we developed a program with Brigham and Women Harvard hospitals, with PIH, that's the program of Paul Farmer in Boston, the late Paul Farmer, NYU, and the College of Medicine in Liberia, the only medical school there. All of those collaborated to develop what we call resilient healthcare system. So this was from really infrastructure. The medical school was destroyed. The healthcare system was destroyed when we got there. So this was a different area that we became involved. This program ran for 5 years. It was funded for another 5 years with $16 million by USAID. We are now at the end of the 4th year, but the program was ended because USAID, as you know, was recently dismantled. But this program has really rebuilt the infrastructure in Rwanda so that they can really begin to build on that on their own. Again, 2 of my young colleagues headed the program. They were still heavily involved. The difference here was that the faculty that we recruited to train Rwandan faculty came from Africa. We recruited faculty from South Africa, from Nigeria, from Uganda, to prove to them that they had the capacity to train their own individuals. They did not have to rely on Yale. They did not have to rely on Hopkins or Harvard to do that. They could do it locally. But Yale was this center that allowed them to begin to look at that and develop a program that was run primarily by Africans for Africans. During the same time, we also had a major program in multiple parts of the world. I will not go through it. Through another funded project for 20 years to send residents from different medical schools in US, Winston and Global Health, to 7 centers we had around the world. These are the centers that we had in both Africa, South America, Borneo, in Malaysia. So during that time, these are the number of people, and I will not go through them. 561 individuals had gone through the program from different medical schools in different programs to our sites abroad. Now, one of our goals during this program, the program that I ran for approximately 15 years, was to what we call decolonize the concept of training, to show individuals in Africa that they actually could become independent of countries and institutions abroad. This was by always having leadership come from both places, always having a bilateral exchange or a unilateral exchange, always assuming that they could take over the program. So the fund rather than through information, knowledge over time by tuning with our faculty. But at the same time, they were the ones who would define what their needs was and how to solve their own problem. That was the goal that we had all through this time. And during this phase, I think we proved, going through the model in Uganda all the way to model Liberia, that that could be an achievable goal. Now, my greatest pride is the individuals that I trained, human beings. And I want to tell you about a few of them and finish my talk. One is Robert Kalisubola, an orphan that through singing through villages, raised funds to go to medical school. I met him when I was a medical student, convinced him to become a nephrologist, came to Yale to train nephrology, went back and developed a program called Access in the village that he was born, where he developed a program which is a holistic program from pre-kindergarten all the way to School of Nursing, all the way to community healthcare workers, providing care to the whole population of about 16,000 in that area. That's what Robert did by going back. He's now the chair of physiology and professor at Macquarie, a person that began from humble background, but now is a visionary in Africa. The other person is Bruce Krianja, actually trained by other Shiraz University Medical School graduate, Dr. Wahid Mohsenin. Some of you may know Wahid. Wahid is a professor of pulmonary. He worked with Bruce, trained in pulmonary. Bruce went back to Macquarie, rose to become associate professor, and developed a lung center, a center for research in lung disease, now at Macquarie, supported by NIH. The third person, Felix Knopf, came from Germany, became a resident at Yale, became a nephrologist. I had him go to Africa. When he went back to Germany, became professor at Charity. He was one of the reasons that Charity began a Center for Global Health, the first one that developed in Germany. Two of my young colleagues have now taken over my job at Yale. Jeremy Schwartz and Tracy Robin were trained by me. They now are running the program, and they all together are working to develop a program in rural Uganda to deal with non-communicable disease that's becoming common in Uganda. Last time I went to Uganda was in 2019. Here I'm standing with a wonderful Will Robert and with Felix coming from Germany and a funder in a clinic that we developed there for NCDs. Here is community healthcare worker going to an individual's home to provide care in diabetes in a small village in Uganda. That's part of the program that is now run by Robert. My greatest love is for Majid Sadiq. And Majid does not want me to praise him, but he's one of the visionaries in the world in global health. He's actually right now recognized by United Nations around the visionaries. There's now an academy named after him called Majid Sadiq Academy in Global Health, funded by about $10 million. This academy right now has its own summit meeting. That's the advertisement for the summit meeting. This was one individual born in Kerman, Sijan actually, came to Shiraz, medical student, resident, faculty, went to the United States, never forgot Iran, but at the same time decided to spend his life really improving the health in the poor section of the world. Now has an academy that works in about 12 countries around the world, training individuals in different areas. And he is one of my heroes. and one of my product of my life, I would say. So let me just reflect. If you want to get involved in what I have done, humility is the first characteristic you have to have. Flexibility. You never know when you walk into a foreign country who you're going to meet and what you have to do. You have to believe in social justice, that all humans are equal, that everyone is able to achieve the highest in the world. You have to be honest with them in what you can do for them. You also have a passion for what you're doing, because the time that you spend on this is never remunerated. It's never acknowledged by anyone. The institution that you work in has to have a global vision, has to have academic values, which means that it can basically train individuals across culture. You should have support from your leadership, I always did, and there has to be support from grassroots, from people below you, to say that's important to do. What's my message to you? My last slide. Take risk with your life. If that's the only thing I remember from my long talk, is life is short. It is horrible to remain in a job that you hate. Take risk with your life. Define what is your core value and remain committed to it. Commit yourself to a career that gives you meaning, also joy in your life. Recognize your limitations as an individual. Mobilize groups, mobilize institutions to help you. Remember, much of life happens by accident. That certainly is true in my life. That's what makes it exciting. I remember Dr. Rollman telling me, chair of medicine, you have a job at Penn, why don't you stay? I said, no, I'm going to go to Shiraz because I have no idea what's going to happen when I get there. And that's what's exciting to me. I didn't expect a revolution. I didn't expect a war, but you never expect what happens in your life. These are all the people who have impacted on my life, from my parents, from my many, many colleagues abroad and in Iran, my family, both in Iran and in US, have been supportive of me, my wife more than anybody else, who has dealt with my crazy ideas for more than 60 years now. Let me leave you with two quotes, one from Albert Camus. Without work, all life goes rotten. But when work is soulless, life stifles and dies. And from Molavi, آب کم جو تشنگی آورده است تا بجوشد آبت از بالا و پست. Don't seek thirst. That's a statement. You have to have a passion. It's not getting to a goal. It is wanting to get to a goal. It is the need internally that says, this is what I need to do. Getting there is a secondary outcome. So آب کم جو شکری آورده است تا بجوشد آبت از بالا و پست. Shakir, thank you. All other languages, I've only learned a few words. Thank you very much.
بسیار سپاسگزار استاد عزیزم. I will say in English that congratulations for all your enormous achievement in a global capacity building, which has made, I'm sure, huge, tremendous effect on the life of many, many people. So you have touched a lot of life in the whole world. I have one question. Majid and Wahid were my classmates. I'm so proud of them that under your leadership, they have reached that point. You know that I chose surgery, so I did not have so much contact with you, so we went to the surgery. But I continue the same passion. And I have been doing this outreach and capacity building in all over the world, from Philippines to Africa to South and Latin America. Every year we go there, and the goal is that not only we help them with their patient, but we try to educate them, learn from them, educate them, and make them independent. I tell them that you should not always look to the West to come and help you. You have to become independent. in that relation, we go there without any limitation. We can do whatever we want, any surgery for them, but we have a limitation of when they come reciprocally to United States, they cannot touch the patient. So the most I can do is that I can put them as a research fellow or assistant, or involve them in the experimental surgery. For example, in the living-related liver transplant that I was very influential to start the program in Egypt. I was bringing them here and teaching them in large animals, in pig and dog, how to do liver transplant. And we are, of course, working a lot in the American College of Surgeons and all the big societies to somehow facilitate a little bit their involvement when they come here. How has been your success in the medicine? Because surgery is a little bit different. How has been your success in medicine? When they come, they can be a little bit more involved.
Yeah. Well, our program, as it evolved, developed a model where anyone who wants to come, for example, in nephrology, they want to be trained to become nephrologists. We demand that they work in that field in their own country. And that may involve a visit by one of our faculty to make sure that they're on the right track and so on. We wanted to learn the invasive procedures where they are. They may need supervision from outside to learn the technique, etc., kidney biopsy, putting fistula in, etc., etc. When they come to Yale, they become part of the clinical team, but they really are observers. Now, in medicine, it's a lot easier, as you know, to really talking to the patient, all of that be allowed. Yes, it's crossing a line, and the line is gray in terms of is that right or not. I've had many discussions with the hospital. The state has told us if the hospital has no problem with it, we have no problem with it. So we're at the level that we allow them to talk to the patient. We allow them to touch the patient always under supervision, but that's at the level that they work. So it has not been as major a problem as it has been in surgery. We have brought people in surgery, by the way, to Yale, but mostly to work in the intensive care unit, mostly work post-op, work on the specific specialized areas in plastic surgery, in pediatric surgery. We have had people coming in and work in that area as well. We have had people in ophthalmology. They have come and spent 6 months a year at Yale, but they always have come with knowledge from their own experience, their own country, partly supervised from far away before they have come to Yale doing that. One of my colleagues, actually, Dr. Tracy Rabin, nationally through organization called CUGH, Consortium for Universities in Global Health, has been working for the State Department, trying to develop a new visa that allows them more activity in US before they go back. It was moving forward until the new president was selected, and the whole relationship broke down. So we have known, but there has been a national visa pathway to allow people to come here, a specific training under a faculty, as they can do in Germany, that they could do that and then go back to their own country. That was stopped, unfortunately.
Thank you. If anybody else has any question from Professor Rastegar, or
Professor Rastegar, thank you very much for a great presentation. Would you please be kind and stop sharing of your files so we can be ready for the next presentation? And thank you so much. And I would like to ask you a question while you are stopping sharing from your computer. I think that I heard, thank you very much, sir. I think I heard that you said that you were lucky or a luck knocked at your door to start this journey. My question to you is, what would you have done if that luck did not knock at your door that day? Where would you be today without all these achievements?
You know, my life has been full of accident, complete. I showed up one day in Madison, having applied only 2 months before, being told that you're too late, you have to wait for a semester. I telling them I'm going to sit here and you can decide about me, and be accepted the next day as a student. So there has been all kind of accidents in my life, but I've always had the vision that I will end up in Shiraz as a physician. I always had. But I left Iran to become a poet and a philosopher. That's why I didn't go to medical school in Iran. I told my father I didn't know I wanted to become a doctor. But I discovered very quickly that I was a horrible poet and I had no fresh idea of philosophy. So I decided to become a doctor, okay? So that was my path. But the vision that I was going to end up in Shiraz never left me. My wife knew that when we met, that I was going to end up there no matter what. When Dr. Allman said, there's a job here, Dr. Ziai came to Penn, by the way, to recruit me to go to Tehran. And when I said no, he asked me why. I said, I want to go to Shiraz. If they haven't measured BUN, I'd like to teach them how to measure BUN. If they haven't done that, I'd like to show them how to do kidney biopsy. Anything that happens there defines my goal in life. I have no idea what's going to happen. So I think that drive never left me at any time. Even right now, I didn't tell during that time with Iran. I didn't want to talk about that because question would be, yes, I've worked in Russia and Africa. What about Iran? Yes, it has been in front of my mind every day, and I have done what I could all through that, being called in to Yale Council office twice for having violated OFAC rules of the university, that you're crossing lines that are prohibited by law. And I telling them I like to be taken from my job before giving in my right to say that science crosses all borders. So you have to have a passion and take risk with it.
Thank you very much, sir. If there are more questions or comments to Dr. Rastegar, please raise your hand or send us a text message through chat. Thank you.
Can I have a question, Dr. Shukramiri?
Yes.
Dr. Nazagatgu, go ahead, please.
I'm sorry that somehow my monitor was not set up well. I was busy and they couldn't fix it in my office. You don't see my picture, but I just wanted to say thank you so much, Dr. Rastegar, for being a role model for so many people that are beyond, even easily counting them. I just want to mention to you that your legacy is spreading everywhere. I'm one of your graduates in nephrology, Dr. Priyanka Chatwani, came to our program, and we were very lucky to have her for about 3 years. And the first day that she came, before being hired to have interview with me, somehow my accent and my white gray mustache reminded you to her, say that you are from Iran and you look to Dr. very look alike Dr. Srastegar. Say, oh my God, you have been trained by him. He is the role model for thousands of like me. I am just so low compared to Dr. Rastegar. You cannot even compare us. But I'm so honored that you just put my mustache to look like Dr. Rastegar. But I'm just trying to say that that moment was so emotional to me. I cried because it was reminding us our beautiful country. It was reminding me those beautiful days in Pahlavi University. I'm so sorry. But
Uh,
in that interview, I couldn't control my emotions. I apologize for this, but I just want to let you know that we are here, but our hearts in Iran. And I'm praying that one day our country becomes liberated and we can go back, even if we have been aged so much, still we can be of some help over there no matter what. I just wanted to let you know that uh, your legacy is going to last forever. And I'm so honored and so proud to call you my mentor, my role model. And when she was talking about you, I was so happy and so proud. Just letting you know.
Thank you, Dr. Nezakat. Dr. Rastegar, you see that how many of your students are in this session. That says a lot. We all have been your student, Dr. Nezakat, me, all the people that you mentioned, we all have been your student. We are indebted to you.
And I can confirm, Dr. Rastegar, that I have had the honor to know Dr. Nezakat from Memphis, Tennessee for many years, and I can confirm that he actually looks like you. Thank you very much. And then the next question is from Dr. Qudsi Madani. Please go ahead, please.
Hi, hello, I'm in Los Angeles, and I'm very lucky that today I listened to your Dr. Rastegar's talk. You're incredible. I've heard about you before, but I never seen your picture or your talk, and what you do for universe, it's unreal. I was the intern with Dr. Muhammad Gharib and Mohsen Ziai, in Markaz Tebi Kudakan for 9 months before I came to US, because I want to be a neonatologist, and I became a neonatologist. This is before revolution. And before I finished my fellowship at UC Irvine in California, the revolution happened, and actually my parents told me, don't come back because you're not going to get along with this regime and system. I didn't go back. A few of my friends came. They did go back, and then they returned. So I stayed here. I did well, apparently. Became a director of a neonatal unit in a very good hospital in Los Angeles. And I did what I could do for it all. But I always feel very guilty. And I don't know what to do with it. Because I promised Dr. Gharib that I'm going to go back and set up ICUs all over the country as much as I could. I don't know, now I'm retired, but very, very feel guilty and nothing. Any advice for this crying woman? Of course, I helped in Iran to graduate 7 medical students from Tehran University, and we the girls from outside of Tehran, from other cities, and then they lived in my parents' house, and we roomed and board, and I paid for it, and I still do some, but not, of course, in your magnitude. But this guilt of not going back to Iran, even with any regime, I can't forgive myself. Anyway, that's my story, and any advice so I can get rid of this nonsense that I live with it, or the real guilt? Thank you.
I really appreciate your comment. I know that it comes from your heart. And the question you raise is a question that many of us have. One of the things I've done at Yale is to convince the department that the bright students from Iran who apply to residency, there's a group that needs to be looked at very carefully. And since they began that about 10 years ago, I've had 3 graduates from Iranian medical schools every year in our traditional program. So 3 out of 36 are from Iran this year. 1 is from Shiraz, 2 are from Tehran. And I talk to them when they come here. They all say they want to go back when the time comes. So I'm hoping that if my generation was lost because of revolution, because of the war, the ones that still have a love for where we come from, I think our job is to transmit that love to them through whatever means we have. Is it through our poetry, our literature, movies, stories, through writing our own memoir so that they can share it with their own children. All of us have a story to tell.
Yes.
Dr. Madani, I did not want to make this a political session, but I can promise you that soon we'll go back to Iran. So all of us who have a feeling about Iran will go back to Iran. Thank you.
I hope so. I hope so. Because my dream, my promise to Dr. Gharib that I will come back, I wanted to go back and set up an ICU, a real big time ICU in Makastebi Kurakan, and then one probably north, one south, and then try to spread neonatal ICU all over the country. And that dream never came true.
But hopefully we'll be doing that in near future. Me and
Thank
Dr. Saidi are working a lot to make plans for the future of Iran's health system. And we are actually talking in the media and have had another webinar last week. And hopefully soon we will go to Iran and make the situation better. And there will be place for all of Iranians. Those who their heart is still in Iran will come back to Iran.
Yes, I live here, but my heart is in Iran.
Yes.
Always. Thank you. Thank you.
Thank you.
Thank you very much. Dr. Saidi, you have your hands on.
Yeah, I want to thank Dr. Rastegar for this inspiring presentation. I think we actually, at PAMA, we also trying to just, go in the same direction. And I appreciate you being involved in PAMA. We're trying to, help the young generation actually to develop their career and find their path. I think that's very important. That's a part of mission of PAMA. And I think with your help and your presence, actually, we can continue this mission. But I wanted to just also tell 2 stories that I have about Dr. Vastegar. Was one when I was a medical student. I never, have an interaction with Dr. Vastegar, but when I was medical student in Tehran University, I think in the early 90s, Dr. Vastegar came to Tehran University and give a talk. That was about the nephrogenic model of hypertension. And that was the first time I heard that the clinician talks about basic science research and how in the lab you can actually find solution to bring to clinic. And that was, at that moment, I said, I want to be like that. And I did. Actually, right now, I'm a surgeon scientist. I'm not a, physician or nephrologist. But, I think despite the fact I never worked with you, but listening to one of your talks actually changed my career. And actually, I choose that path. I want to thank you. The other, I think, thing I want to point it out, for a couple of years, I was working at the Rhode Island Hospital at Brown University. And several of our nephrologists were trained at Yale. And when I asked them, do you know Dr. Rastegar? Oh my God, you have to see their reaction. They were so, the way they talk about you, that you were everything to them. And it seems that you haven't touched only lives in US or outside, but many, of your trainees are outside of your institution or outside this country and continue this path. And I said, you have just very inspiring story. I think I really appreciate you being here, and I hope that you can also inspire young members at PAMA to basically continue. I want to thank you for this very inspiring story and been involved for so many decades.
And being our honorary member.
Yes.
We are
Thank you very
proud
much.
that he accepted our honorary member.
I'm honored. Thank you so much for inviting me.
Thank
Have a
you very
wonderful day.
much. With
Thank you.
Dr. Rastegar's permission, I would like to give a comment to Dr. Madani that, as Dr. Rastegar mentioned, we all have to take a risk in our life at some point. Dr. Madani, you and many other Iranian physicians and other highly educated, you took the risk in your life. You moved from Iran to Los Angeles and you did your best to help humanity in Los Angeles. Humanity is universal, so it doesn't matter that human is in Africa, in Iran, in Russia, in Germany, in Los Angeles, or in Uganda. You did your best with the neonates in Los Angeles. Dr. Rastegar and Dr. Majid, they did their best in Africa. We do our best everywhere we are. The whole planet of Earth is our home, and we have to do our best. And this is the meaning of the poet from the Sa'di, بنی آدم اعضای یک پیکرن. در نتیجه همه ما در هر جا که هستیم میتونیم کمک بکنیم و خوشحال باشیم که داریم اون سوگند پزشکیمون رو که خوردیم به هیومانیتی در هر جا که هست میتونیم ارائه بدیم. البته عشق به ایران چیز دیگری است در ماها که ایرانی هستیم و اون هم همونطور که دکتر حسین شکوه‌امیری گفتن روزی به واقعیت خواهد پیوست. با اجازه دکتر رستگار معذرت می‌خوام.
Thank you so much.
خواهش میکنم.
خداحافظ.
خب خداحافظ شما دکتر رستگار، خیلی ممنون از شما. و اگر پرزنتر بعدی که آقای دکتر لفتاوی باشند اگر جوین کردن به ما میتونن بگن که هستن در این گروه. اگرم هنوز جوین نتونستن بکنن به دلایل فنی و یا وقتی، ما میتونیم از اسپیکر بعدی که آقای دکتر حسین شکوه‌امیری هستن خواهش کنیم که پرزنتیشنشون رو شروع کنن. دکتر متین اگر شما شیر بکنید برنامه ایشون رو، و اگر دکتر لفتاوی دیرتر وارد شدن ما میتونیم نوبت رو بدیم به ایشون.
من میخواستم خواهش کنم که اگر جناب دکتر وقت دارن تشریف داشته باشن در برنامه ما. دلم بخواد که نظر ایشون رو در مورد برنامه ساینتیفیک پاما هم بدونیم. جناب دکتر رستگار، you're welcome to stay.
متشکرم. دکتر رستگار هستند. در نتیجه ما برنامه رو ادامه میدیم با پرزنتیشن شما. دکتر سعیدی بفرمایید.
Yeah, I think our next presenter is Dr. Shukwu-Amiri. He doesn't need any introduction, and he's going to talk about change in BMI after simultaneous kidney and pancreas transplantation in type 1 and type 2 diabetes.
Dear colleagues and friends of PAMA and the listener and the viewer to our annual meeting, scientific meeting this year. As you know, the best treatment for diabetic mellitus is the pancreas transplantation. And there is no treatment, no matter how tight they have been. None of them have been able to produce hemoglobin A1C under 6. The only thing which does this one is the pancreas transplant. So pancreas transplant is very well established treatment for type 1 diabetes mellitus. Go to the next slide, please. I have no conflict of interest with or any of the authors that are with me. And I just give you a little information about the, how many people we have globally are suffering from diabetes mellitus and living with diabetes mellitus. See, 11.9% adult and between 20 to 79 years. This is the IDF Diabetic Atlas in 2024, and 853 million will be affected by diabetes by 2050. And in USA, there will be 27.9 million or 8.9% of the population will suffer from diabetes mellitus. So this is a very important issue. So our job is to somehow, even though we cannot transplant, and not everybody is a transplant candidate, for helping the people. Next slide, please. We know that the majority of diabetic patients are type 2. 90% are type 1, type 2, and only 10% are type 2. The contributing factor for increasing the incidence in this world is urbanization, aging population, decreased level of physical activity, and increasing overweight and obesity, which mainly takes in type 2 diabetic patient. Type 1 are by definition, they are not obese and they start earlier in their life, but type 2 has been like that, and it has been ignored from this treatment option, which has proven to be very successful for type 1. Next slide, please. Next slide, please. Now, we see the magnitude of the problem and economic impact that diabetes-related health expenditure surpassed $1 trillion globally in 2024. Some countries have extraordinarily high incidence of diabetes, like Pakistan, which has 26% of their population are living with diabetes mellitus. France and Denmark, Spain, Switzerland, and Sweden have the lowest one, and ADA recommends A1C measurement of less than 7 to reduce the risk of complication. But unfortunately, with increasing obesity, this is coming out of control. Next slide, please. Now, these days, you all hear about the effect of a GLP-1 receptor agonist on A1C, and when added to metformin, this will decrease the level of hemoglobin 1C by 1.5 to 1.8% point. Still, you can see that even though this is very successful treatment so far, the transplant brings the hemoglobin A1C under 6, a successful transplant. I have patients that we have transplanted almost 30 years ago. Still, they are functioning very well, and their hemoglobin A1C is 5.4, 5.6, like a normal person. Next slide, please. So this slide shows that how many transplants have been done during all these years. This is from the UNOS data that we have. So we have a large amount of a number of patients that have been transplanted, and year by year you can see that how many transplants are done all over the world. Of course, the last line, which is living donor, is not done everywhere. Very few have been done in University of Minnesota, and they have almost abandoned that one, because by having a living donor, you put the donor at a risk because they lose half of their pancreas and they may develop themselves diabetes. So this even, and also is a very difficult operation. It has not been very successful. So the majority of the pancreas transplant are deceased donors. Next slide, please. This is the technique that we have designed in the pancreas transplant. I started working on the pancreas transplant in animal model when I was in Denmark, a study which took 7 years. And we proved that the portal enteric, which is the natural way of delivery of the insulin to the body, is better than the systemic type of transplant, which is the used everywhere by hooking the endocrine function of the pancreas to the systemic circulation, which creates hyperinsulinemia. And we believe that hyperinsulinemia is a risk factor for the macrovascular and microvascular disease. So we work on that, and they did the first pancreas transplant in human beings in October 10th, 2000, in 1990 in Memphis, when I came from Europe, from Denmark to United States. We did it in both hospitals. 5 of them we did, and we presented the result in Lyon, in one of the international islet and pancreas transplant society. And since then, it has been adopted by some centers in the United States. The exocrine part of the pancreas was drained initially to the bladder, which proved to be not good, and then later to the bowel. And then now we are hooking it to the stomach, which we believe the ultimate of technique that we have used, because it makes it easy access to the pancreas through endoscopy and make the problem a little bit easier. If you go to the next slide, please. So we decided that why we should not do this one for the type 2. Not every type 2 is candidate for getting a pancreas transplant, but some are. And we know that the pathology of the type 2 is different from type 1. In type 1, you do not have insulin production. Somehow something happened to the pancreas, but in type 2 is the insulin resistance, not insulin deficiency. And that because of the extra fat and obesity. So we try those that have exhausted their pancreas and approaching from type 1 to from type 2 to type 1 to reduce their weight to see what will happen. So if somebody has a BMI of 38, 40, we work with that patient to bring it to around 30 to 28. And then if still they need insulin, so they become like type 1, we transplant them. And in our center, we have, which was one of the centers that we started type 2, transplant for type 2, we increased the activity from 3.6 per year to 11.8 per year. So increased substantially. Next slide. And the aim of the study was to compare BMI changes of the pancreas transplantation, which is usually combined with the kidney, between type 1 and type 2 patient. Because we knew that the problem with type 2 was the weight gain. And now if we can control it, that will be good. And if not, then we have to do something. The secondary aim was to evaluate 5-year kidney graft and pancreas graft survival and patient survival. Next slide, please. We did a retrospective cohort of our patient between 2013 and 2024. And 120 patients we transplanted with this technique of portogastric. 68 of them were type 1 and 52 of them were type 2. And data, we measured the BMI, C-peptide, hemoglobin A1C, GFR at pre-transplant, 3 months, 6 months, 1 year, 3 years, and 5 years. And graft and patient survival was assessed by Kaplan-Meier analysis. Next slide, please. This is the result of the thing. You'll see that between type 1 and type 2, age is different, significant statistically, because type 2s are older a little bit. The BMI, we brought it to a level that we can transplant them. So BMI is not that big of a difference, but C-peptide, again, you see that the type 2s, they have C-peptide, but insulin resistance, but the type 1, they have very low, almost zero C-peptide. Hemoglobin A1C in both of the groups were abnormal, and this is the GFR in the type 1 was 11 and type 2 10. So both groups were somehow comparable. And next slide, please. This is the result after 5 years of following this patient. Of course, we have patients that we have transplanted 20 years and they are working fine, but this is the 5-year result. You can see that the hemoglobin A1C in type 1 and type 2 and their p-value, you can see, and also C-peptide and GFR, you can see that one, that it works nicely. And when you see a hemoglobin A1C of 7.2 in type 1 and 6, these are because it's the average. Those that have failed, of course, their C-peptide is higher, so that brings it to a little bit higher. But those functioning pancreas transplant patients, they have a great hemoglobin A1C and C-peptide. Next slide, please. This is again the change in the weight, BMI, that we can see that in type 1, they keep it well under control, but type 2 start going up because they have a tendency, they have been living with that one for the whole life, and now they have got a transplant, they have been under strict regimen, they have tried to control, but when they get transplant, they feel much better. They do not need to go to dialysis. They do not need to have insulin injection or anything like that. So they feel better, and they forget that they have to control their weight. And so they start gaining weight. And again, you can see that the BMI goes up. So that was an alarm for us, wake-up call, that we have to somehow control these patients better. Next slide, please. And so these are the outcomes and the p-values. You can see patient survival is excellent, up to 5 years. And in both group, of course, type 2, they have a higher mortality because they are older age. And also they have had already a severe macrovascular disease and microvascular disease. There are different type of patient pathology, but as a whole, the result is excellent. Next slide. Yeah, this is the way that we are measuring them. Next slide, please. And then to the conclusion, that we thought that if, except the way that we were doing after transplant, when we saw this trend to put extra classes for those type 2 patients, to educate them on their nutrition and their level of activity, to make sure that they do not gain weight. But we believe that if we combine GLP-1 RA to this type of select type of patient, because not every type 2 patient will require GLP. There are some centers that they automatically they combine these two. The medicine is very expensive, has side effects. We do not believe that everybody should use it, but those that we fail to get control of their weight, then we can add that one, and that will be helpful. I think the future will show that how combination of these transplant and GLP-1 will help them successfully. Thank you very much for the pleasure of giving this talk. Thank you.
Thank you very much, Dr. Hossein Shukr Amiri. If there are any questions or comments to his presentation, please raise your hand or send us a message through chat. And I have a question from Dr. Zahra Bagheri in the chat. I read the question. Hi, and با درود فراوان to Dr. Rastegar. He didn't mention that during the BAM earthquake in Iran 22 years ago, he led the U.S. team sent from the U.S. to Iran. Dr. Rastegar was and still is a hero and a role model for many students and professors. Thank you very much, Dr. Zahra Bagheri, for your comments. Dr. Shafa Amir Sultani has her hands on. Please go ahead, Dr. Amir Sultani.
با درود به همه عزیزان و بسیار سمینار خوبی است. تشکر از همه. یه سوالی از آقای دکتر حسین شکوه امیری داشتم. میخواستم ببینم فرمودید که ترانسپلانت برای از کسانی که فوت کردن راحت‌تر و بهتر یعنی سکسسفول تره تا اینکه از کسی که زنده است. و طبق آماری که دادین در آمریکا فقط 48 نفر از زنده چیز کردن، در صورتی که میدونیم در ایران خیلی کلیه میفروشن. شما اینو چجوری میبینید؟ در ایران مردم به خاطر پول کلیه میفروشن. خواستم نظرتون راجع به این بدونم. و خیلی هم هستن که در ایران به اصطلاح فانکشن میکنن و البته هیچ کس نمیدونه بعدش چی میشه. خواستم نظرتون بپرسم.
خیلی ممنون از سوالتون. من و دکتر سعیدی دقیقا میدونیم چه اتفاقی میفته در ایران و البته کلیه 2 تا هست. 2 تا کلیه رو میشه یک شو به اصطلاح داد. در مورد کبد میشه قسمتی از کبد داد، ولی پانکراس یک اکسپریمنت ساکسسفولی نبوده. فقط در یونیورسیته مینسوتا انجام شد. اون پایونیرینگ سرجنی که اونجا بود، دکتر نجاریان و دکتر که تا اخیراً سادرلند که فوت کردن و گروهی که اونجا بودن این کار سعی کردن که کمک کنن، ولی متاسفانه ساکسسفول نبوده. در مورد ریه شما میتونین از لیوینگ ریلیتد بردارین، اسمال باول میتونین، کبد میتونین، کلیه میتونین، ولی پانکراس به همین دلیل میبینین که فقط 48 تا در آمریکا شده، جاهای دیگه نمیکنن این کارو و در بقیه جای دنیا هم من اطلاعی ندارم که به طور روتین این کار رو انجام بدن. ممکنه یکی دو تا انجام شده باشه ولی به هیچ وجه living related pancreas transplant successful نبوده. فرق میکنه با بقیه اندام.
متشکرم.
دکتر امیری توی ژاپن لیوینگ دونر پانکراس ترانسپلانت بیشتر جاهای دیگه پرکتیس شده، ولی واقعا منم نمیدونم که الان پاپولاریتی پیدا کرده یا نه. ولی سوالی که از شما داشتم در ضمن این که میخواستم بگم پرزنتیشن بسیار مفیدی بود و ممنون هستم. من خودم از اکثر استعداد شما عکس گرفتم. عرض کنم که جالب هست که پرسنتیج کسایی که تایپ 2 دیابتیک بودند خیلی سیگنیفیکانتلی بیشتر از تو کوهورتی که شما داشتید بوده. تقریبا 40-45% تایپ 2 داشتید و بقیه 55-60% تایپ 1. توی سنتر ما تقریبا میشه گفت که شاید مثلا 15% تایپ 2 باشه و بقیه تایپ 1 هست. نیشن واید هم این الان تقریبا 20%. علتش به خاطر پاپولیشن میکاپی هست که شما توی لویزیانا دارید یا اینکه پروتکل شما اساسا خیلی لیبرالتر هست که تایپ 2 دیابتیک پیشنت ها رو اینکلود بکنه؟
بله، این خیلی ممنون از سوالتون. این اینتنشنال بود. ما میخواستیم نشون بدیم که تایپ 2 هم میتونن به اصطلاح از پانکراس ترانسپلانت بهره‌ای ببرن. به این دلیل ما پروتکل رو نوشتیم و از 2004 البته قبلا هم کرده بودیم اسپورادیک، ولی از 2014 روتینلی ما انجام میدیم و حتی بیشتر هم میشه، چون پانکراس ترانسپلانت وقتی که نیازی به اصطلاح فانکشن آیلت داشته باشه و آیلت ها دیگه فانکشنال نباشن، پانکراس ترانسپلانت کمک میکنه. یا آیلت در آینده یا اینکه الان هول ارگان ترانسپلانت کمک میکنه و خیلی ساکسسفول بوده و ما در چندین جامعه بین‌المللی و ملی هم اینو پرزنت کردیم و امیدواریم که تعداد بیشتری تایپ 2 عمل بشن. بنابراین اما در مورد ژاپن که سوال کردین، جایی ساکسسفول به اون صورت نبوده. علتش هم ریسکی است که برای دونور هستش. شما وقتی عملی انجام میدین باید ریسک بنفیتش رو ببینین. با اینکه تکنیکش تکنیک مشکلیه برداشتن پانکراس و کامپلیکیشن هایی که ممکنه بده، ولی انجام پذیر هست. اما ریسکی که برای دونور هست، دونوری که سالم بوده میاد به یه قسمت از پانکراسشو میده، احتمالی که خودش دیابت بگیره هست. بعد ممکنه که اون قسمتی هم که داده برسی بیاد اونم بگیره، هر دو فیل میشن. مثلا در مورد لیور اینطوری نیست. لیور قسمتی برمیدارین، لیور ریجنریت میشه و در هر دو، هم در دونور هم در رسیپیانت کار میکنه. یا در مورد کلیه برای مدت طولانی این کلیه ممکنه کار کنه بدون که هیچ اشکالی نه برای دونور به وجود بیاد نه برای رسیپیانت. ولی در مورد پانکراس اینطوری نیستش. بنابراین پانکراس پرکتیس نشده.
سوال دیگه که داشتم این هستش که تایپ 2 دیابتیک پیشنت هایی که شما داشتید بدون استثنا همشون اینسولین ریکوایرمنت داشتن یا اینکه شما
بله.
چون شرط خیلی مهمی هست؟
بله حتما. یعنی ما کسی که روی اورال دیابتیک ایجنت هستش که بهشون ترانسپلانت نمیدیم. اینا به اساس پپتاید دارن، درمان اینا ریداکشن اف ویت هستش. ما همه اینا مریضایی که میبینیم خیلی از اینا میشن آن کاندیدیت، برای اینکه وقتی وزن کم میکنن دیابتشون بهتر میشه.
حقیقا.
و این درمان دیابت تایپ 2 ویت ریداکشن هستش. حتی اوبسیتی سرجری کمک میکنه به اینا چیزایی هستش که ما خیلی استریکتلی فالو میکنیم و اونایی که دیگه به جای دیگه نرسه و کمکی نشه بهشون ترانسپلانتشون میکنیم.
متشکرم. Thank you. دکتر سعیدی شما دستون بالاست.
من هم یک کامنتی میخواستم بگم، چون اشاره شد که در کشورهای دیگه از لایو دونر استفاده میشه. چند مورد در ژاپن انجام شد که از لایو دونر استفاده شد برای آیلت، که دونر رو به صورت لاپاراسکوپی دیستال پانکراتومی کردن و از اون آیلتاشو گرفتن. ولی همونجوری که دکتر امیری گفت چند تا از اون دونرها خودشون دیابت گرفتن. مشکلی که وجود داره این که آیلت ها در پانکراس به صورت هوموجنس پخش نشده. در بعضی افراد آیلت ها ممکنه بیشتر در سر پانکراس باشه، در افراد ممکنه در دم پانکراس باشه. ما هیچ تستی نداریم که بتونیم بگیم چطور پخش شده. واسه همین به علت ریسکی که برای خود دونر داره این الان منسوخ شده. ولی من یک کیس جالبی برام پیش اومد، بخوام نظر دوستان رو بپرسم. من چند سال پیش که ایران بودم چند تا پیوند پانکراس انجام دادم و بعد یکی از سرپرستارهای بخش اومد من گفتش که از دونر از زندم شما انجام میدیم. گفتم نه، به از اخلاقی نمیشه انجام، چون دونر ممکنه دیابت بگیره. اون گفت بچه من دیابت داره، من حاضرم رضایت بدم شما پانکراس منو در بیار ترانسپلانت کن به اون بچه من نتونستم جوابشو بدم. میخوام نظر شما چیه؟
من هرگز هم چیکاری نمی‌کنم و بهش توضیح میدم اگه پانکراس شو، اولا گفته پانکراس منو برداره، یعنی هول پانکراس.
بله
پانکراس میدونیم دو
پانکراس
تا
منو بردار.
وظیفه داره، هم اکزوکراین داره هم اندوکراین داره. یه چیزی است که lack of education در این مورد. باید اون کسی که ایموشنالی انقدر تاچ هست که بخواد کمک کنه که کاملا قابل قبوله، باید روشنش کرد که راههای دیگه هست. این راه درستی نیستش، از راههای دیگه باید استفاده کرد. منم الان مریضای دارم از ایران با من مرتب تماس میگیرن که کی ترانسپلنت چجوری بشه. من ادوکییتشون میکنم، مدت ها وقت صرف میکنم باشون، میشینم پای تلفن صحبت میکنم و بهشون میگم که چی درسته چی درست نیست. هر چیزی که مریض بخواد ممکنه که ایموشنال باشه و درست نباشه.
ولی میگم این مریضی بود که یعنی دونر کاملا اینفورم بود، آدم تحصیل کرده بود، میگم من تمام ریسکشو قبول میکنم.
من نمیکردم این کارو.
نه منم نکردم، ولی میگم
بله.
واسه من جالب بود که مادر چطور حاضر همچین چیز.
بله این حقایقی هست در مورد مادر بودن یا پدر بودن. خیلی چیزای عجیب غریب آدم میبینه تو زندگی.
خب یک سوالی، آیا درسته که نمیشه به صورت کامپلیت پانکراس رو ورداشت و ترانسپلنت کرد در بچه، ولی آیا امکان داشت که به صورت پارشیالی، با وجودی که ندونیم آیلت ها کجا هستن، ولی آیا پارشیالی میشه این کار رو کرد؟
همون کاری که گفتم که تجربه‌ای که در یونیورسیتی مینسوتا بوده پارشال بوده. تمام اینا دیستال پانکراتکتومی بوده، همونا ساکسسفول نبوده. یعنی تجربه تاریخی نشون داده، به همین دلیلی که 48 تا بیشتر ندیدین تو اون اسلایدایی که من گذاشتم، یا اسپورادیک چند تا توی به اصطلاح ژاپن کردن این ور اون ور، چیز ساکسسفولی نیست. و ما در حقیقت وظیفمون خدمت در راه درست هستش، نه اینکه هر کسی هر چیزی بخواد. یه مریض دارم همین شب و روز تلفن میکنه و اصرار میکنه که به من الان استمسل بگین ترانسپلنت بکنن. یه جا شنیده یه کسی یه چیزی گفتم اینا حقایقی خواهد بود که ممکنه 10 سال 15 سال دیگه ریالیتی بشه، ولی امروز نیست. بچه‌م توی که حتی یک قرون نداری که با من تماس میگیری همه چیز از من میخوای. $700,000 در دیروزم گفتم تو برنامه اخیری که صحبت شد، خرج یک دونه استمسلی کردن. 2 تا در چاینا کردن، یکی 2 تا در به اصطلاح هلند کردن. طولانی هم نیست. بعدش هم باید سنترهای دیگه هم تکرار بکنن، برای یه سنتر ممکن دروغ بگه، ریسرچش قلابی باشه. باید این حتما در سنترهای دیگه هم اجرا بشه، ثابت بشه که این درسته، بعد بیاد به کلینیکال سیچویشن. همینطوری نمیشه به هر چیزی فوری توی یه مقاله نوشته شده آدم اکتفا بکنه.
متشکرم. آیا سوالی، کامنتی نسبت به مقاله ارائه شده هستش؟ اگر نیست من سوال بکنم که آیا آقای دکتر لفتاوی به گروه جوین شدن که پرزنتیشن خودشون رو ارائه بدن؟ آقای دکتر لفتاوی آیا در گروه هستید؟ اگر در گروه نیستن دکتر متین، ما میتونیم بریم سراغ پرزنتیشن بعدی که آقای دکتر امیر صنعتکار فکر کنم آماده هستن. اجازه بدین که دکتر متین شما رو وصل کنن و شیر بشه با شما و شما پرزنتیشنتون رو بتونین ارائه بدین. Thank you.
Okay, our next presenter is Amir Sanatkar, who presented yesterday too. He's a former research fellow at MGH and current surgery resident at NYU, and he's going to talk about neutrophil extra trap formation after xenotransplantation, a potential contributor to inflammation and thrombodysregulation.
Dr. Sanatkar, I know that you're working and Matin is working, but we don't have your voice. There might be a kind of sharing voice.
Can you see my slides?
Yes.
Okay.
All right. Do you guys hear me well?
Yes.
Good.
Please go ahead.
I
Yes,
apologize. Thank you very much. Thanks again for the opportunity here for PAMA. I think today's discussion was a little bit emotional earlier. As another side, we also have the same feelings, but we also appreciate that there's a gathering here that we can.
Your talk is
Here in the U.S., unfortunately. So Nets, this is the.
Dr. Sanatkar, give me a second. Dr. Sanatkar, please stop. Give me a second. Dr. Matin, the sharing is with the voice is not optimal. If you have shared with Dr. Sanatkar, you have to do it on your side. If not, so there is a gap, there is a delay in the voice and talk.
I think he did it himself successfully yesterday.
Yeah, but I don't think I have it right now.
So let them
Okay,
then, Mateen and Mohammed, they take care of it.
Okay, sounds good.
It might be from your microphone. So try to work on what you have on around your head. Try to check them.
Maybe.
Yeah, it's good, but try.
Okay.
And reception.
Can we go? So this is the, should be okay.
Go ahead. Yeah,
Sounds
go
good.
ahead.
Okay,
thank
so this is the actual presentation that I was supposed to present 2 weeks from now in International Xenotransplant Association, and that's the word of that conference where I'm really happy to be able to share it here. Disclosure none. Next, please. So we discussed about this yesterday. I'm not going to go to details. The whole idea is that to increase the donor pool because we're not really catching up with the demands that we have here. So that's the whole idea of people who are interested in Xeno. But again, so many challenges. What we've been doing is to make pigs okay enough to be able to transplant and have a meaningful survival, which for that we're being knocking out several genes that have been associated with acute and hyperacute rejection, but also adding some human transgenes because over time we've learned that there are so many other issues, including complement factor overactivation, coagulation, and inflammation. So human transgene insertions has really dampened those, but we will still have room to work with. Next, please. And that's the idea and the goal that we have for future to have like off-the-shelf organs. Next, please. So I presented a little bit about neutrophils and how I got interested in working on them yesterday. But what was really digging around to see if I can add another project, it was very interesting to me that our experience of perfusing pig organs with human blood and also in vivo transplants of pig organs into non-human primates were almost always showing us a very early drop in platelets, neutrophils, and RBCs in the perfusates and also in the recipients. And we really didn't have a very good explanation why, but that was a vicious phenomenon that the non-human primate recipients were failing, and that was the end of a study very early on. So I was trying to find a way that what can explain all these things at once, that why do we see a huge drop in platelets and then neutrophils and RBCs afterwards. Next, please. So the basic of the projects, except if you just put the in vivo transplant sites aside, the ex vivo circuits was the mainstay of the projects that we've been working on, which basically for those who know or don't know, this is a simply say is that the cannulation of the organs and perfusing with the human blood. My case, again, organs are from pigs, from different genetics, wild type, as the positive control, negative control will be a discarded human organs that I was able to perfuse 50, 60 of each for the past 2, 3 years. And again, almost always seeing a huge drop in CBC markers. Next, please. And again, I showed this yesterday that pigs are prone to ischemia reperfusion, probably neutrophils play a role. Next. And next. So it was just by luck that I was trying to take a look at the literature. I found and got interested into the extracellular trap formation from netosis. This is a very relatively early or like new finding back in early 2000s, that it was found in septic patients that neutrophils behave differently, and when they get super activated or interested in something going on in a septic patient, they expel all the DNA out. And that will cause secondary and tertiary phenomenon that can be vicious. Just to mention, after septic situations, people in inflammatory conditions who were working on those, including SLE, found that the double-stranded DNAs, which is part of the diagnosis of lupus, is because of a DNA coming from these neutrophils out, meaning that there's an inflammation going on in the body, that the neutrophils get crazy and expel their DNA, and over time they make antibodies against their own DNA. So if you move forward with the more literature, you see that recently they found that these DNAs can be a very good scaffold for complement factors to sit down and get activated, but also for RBCs to get shattered, and also platelets to get shattered. So sort of in my mind, I thought that it sort of explains everything. Next, please. So this was a recent paper that showed that the trapped chromatin fibers coming from these netoses can lead to RBC hemolysis, which we were seeing as part of the Xeno. Next. Next. Again, looking into the literature more, I found that like many of the COVID patients who deteriorated, they got their lung tissues out and they stained it, and they saw that there are lots of nets forming or extracellular traps formation in their lungs, and it was actually associated with higher mortality, pretty much similar to the lungs that I showed you in previous slides today and yesterday. Next. So this is a video, if we can play, hopefully we can play it this time. This is just a sample of, yeah, I think we can. Wonderful. So you see the neutrophils, their DNA are becoming thicker and then expelled out of the cells. And this is basically a first line for fighting to bacteria, because there are some bactericidal particles inside that. But again, if it's in an uncontrolled way, it can damage and it can lead to more problem for us. Next, please. Next slide. Thanks, Matinja. Lovely. But again, going to the details, you see that there are two main types of neutrophil extracellular traps. One is a late suicidal nets, which is the typical thing that we've learned, which the whole part of DNA would come, but it takes hours for the neutrophils from the time of stimulation to send the DNA out and cause all the trouble. The second type is, which is like a few years ago been found, is the early vital netosis. They send only some part of their DNA. So the neutrophil is still active and can cause trouble for you, but it's also sending the DNA, which includes all the material that can activate complement factor and also can shatter the RBCs and work with against the goal that we have. Why it matters, I'll show you in a second. Next, please. So I had the platforms, I had the ex vivo perfusions ready that we always had in the lab and going on, but also had to find if we see this netosis first in the xenotransplantation world, and then second to see if we can do anything against it and increase the survival. Next. So this is how I designed the experiments. I thought that I have to prove that they are in vitro present, and ex vivo present, and in vivo present. For in vitro, I designed some flow cytometry studies that I'll explain a little bit. On ex vivo circuit I just explained, I was working on heart and lung ex vivo perfusions, and I could just take the perfusates and look for the extracellular traps or DNA outside the inside the perfusates. And also, we always have pig-to-baboon transplant models that we used to do like at least once a month. And for the past two years, I could just go back and look if I see them present. Next. So for flow cytometry, I don't want to go to details, but I put the pig endothelial cells and buffy coat, which included neutrophils of human, together for only 15 to 30 minutes to see if I see the early or vital netosis that I showed you, and then stain for markers associated with extracellular traps and run flow cytometry, which I did. Next, please. And this is how I did the gating. I don't want to like go for that details today. Next. Well, this is the results. So basically the upper right square is the double positive. So I had two markers to make sure the DNA that I'm seeing is not from dead cells, but it's from the dead neutrophils. So if you see on the vertical axis, it's neutrophil elastase, part of a netosis, and the horizontal one is the DNA, which I use different antibodies for. So double positive on the first left-hand side is 30%, meaning that if I just put the cells together and stimulate neutrophils with PMA and endothelial cells with TNF-alpha, which is very much high levels post-perfusion, almost always in vivo, you will see a very much positive markers of presence of nets very early. And next, please. That's where I'm talking about. Next. So again, I described this is the device that I had I could use in microvasculature and see what's going on in a small microfluid channel system. I use this also here for this experiment as well. Next. Next, please. This is the plates again, as before. Next. I explained how it works. One will is input, one will is output. I put endothelial cells, let them grow on the channel and the horizontal channel in the lower side, as you can see, and put the microscope when I perfuse with human blood. Next, please. Next, please. I don't want to go to details for today. Next. Next, please. And then for perfusion, I always do 60 minutes of perfusion of human blood over pig endothelium and take 180 photo images and make a video. Next. So, okay. Can we play these? Great. Okay. So the arrows are shifted a little bit, but basically the top and bottom are same channels and using different antibodies, different images. I mean, they should be the same. Do you see the dots on the top and dots on the bottom? Well, the top ones are green and DNA, the bottom ones are neutrophil elastase. So if you see both markers positive, it means that that's the DNA coming from neutrophils. But if you take a little bit more attention, you see that they are present in the start of the perfusion, meaning that it takes this few seconds for them. Nobody has reported neutrophils to send their DNA out after any sort of transplantation, which I assume Xeno is making neutrophils so crazy that they expel their DNA within minutes, not hours. Next, please. We can go to next slide. Great. And next, please. So I worked with Dr. Irimia, who is world-renowned for neutrophil extracellular traps. And so I took the perfusates from ex vivo perfusions we had from different time points and worked with them, used their microfluid device that they have, and to see if we see netosis really happening in ex vivo as well. So we proved on in vitro, this is the ex vivo level. And all the green dots you can see on the lower side, time point 0, time point 5 minutes, and 15 minutes. And see, 15 minutes, they're almost all positive, meaning they get angry within minutes. Next, please. Next. So this is the results of ex vivo perfusions. You can see on the left-hand side, I perfused 4 lungs of 10 and 11 great genes with human blood, and you see a very rise in neutrophil extracellular traps levels within 5 to 15 minutes, and then goes down. On the right-hand side, you see 2 hearts of pig hearts being perfused with human. Again, you see a rise. So to me, that says I can see them in ex vivo perfusion settings as well. Next, please. So I worked with one of our lab techs who is a medical student in Colombia now. She was very smart. We decided to look into historic samples that we have from the in vivo pig to baboon heart xenotransplant models with an ELISA that we developed in the lab. Next. And it's amazing for me that I checked this results with so many different markers, and sort of they go along and similar to how CRP is being up into the animals. So we have a very high inflammation after xenotransplantation, but to me, neutrophil myeloperoxidase, MPO, which is one marker of neutrophil extracellular traps, mimics CRP, but also it rises even earlier than that. That can be a diagnostic factor. Next, please. This is sort of the conclusion of what I just mentioned in vitro flow cytometry and in the device that I had, and ex vivo from hearts and lungs. And finally, I'm still working on so many in vivo transplant models, retrograde, looking at them, and hopefully will be the combination of all settings to publish that neutrophil extracellular traps is something that we have to deal with and maybe insert new genes into pigs for better survival. Next. And this is my face every time in the lab for past 3 years, because for every of the results that I got, I had to I failed 10 times and maybe got some sort of results in one time. Next. And with that, I want to appreciate and thank you all for listening, getting me the opportunity to present here, and all the mentors that helped me for the past years. And of course, that's my daughter on my back. Thank you very much.
Thank you very much, Dr. Sanatkar, for an interesting presentation. And if there are any questions or comments, please raise your hands. And it seems that Dr. Amiri has his hands on. Please go ahead.
Congratulations for your nice work. But as you know, when it comes the issue of transplant, there are 2 factors. One is the endothelium of the organ. One is the neutrophil of the recipient. And the immune system of the recipient, which the first hand is the neutrophil and the platelet, which destroy the organ. So when you are going to implement this one, are you trying to change the genetic makeup of the endothelium of the organ from the xeno, or changing the immunosuppression in the recipient that will prevent the neutrophil of the recipient attacking the endothelium of the organ?
Fantastic question, Dr. Amiri. So yes, actually it's both, because so we have seen, if you know that, like for the at least xeno side of the immunosuppression, we are implementing co-stimulation blockade pathway, which we have shown that makes the neutrophils a little bit less sensitive, but not enough. So on the other hand, we're working on few markers that we think, if being put on the endothelium of pigs, they make neutrophils more and more less sensitive, and hopefully with that way we can dampen the injury that these neutrophils are causing over the endothelium and leading to primary graft dysfunction and then later rejections.
Thank you.
Any more questions or comments to Dr. Sanatkar? If not, we go to the next presentation by Dr. Qambari. Dr. Saidi?
Yeah, our next presenter is Dr. Qambari, Faiza Qambari, who's going to talk about how is health insurance coverage associated with general health and healthcare access among U.S. adults with diabetes.
Good afternoon to everyone in the US and good night from Iran. My name is Fayaz Ghambari. I'm a medical doctor from Iran and I'm affiliated with the Tabriz University of Medical Sciences. I just wanted to apologize in advance for any disconnection or poor internet connection. The title of the study that I am presenting today is How is the health insurance coverage associated with general health and healthcare access among US adults with diabetes across different age, sex, race, and ethnicity groups. Please next slide. Diabetes is a chronic disease with no cure and requires continuous medical care. Effective management of diabetes depends on regular checkup, a personal healthcare provider, and affordable access without financial barriers. General health is an outcome measurement and provides insights beyond life expectancy and reflects quality of life in chronic illnesses. Poor general health in diabetes increase the risk of complications such as anxiety, depression, and physical or cognitive impairment. Health insurance is essential for equitable healthcare access, and lack of coverage may worsen outcomes. Please, next one. Our main goal was to examine how health insurance and general health are associated across different age, sex, race, and ethnicity groups. Or in other words, which age, sex, and racial groups of diabetes patients are more likely to benefit from having health insurance according to the general health and healthcare access status. Please, next one. Data that was used in this study was from the BRFSS 2021 to 2023. The BRFSS stands for Behavioral Risk Factor Surveillance System, which is an annually conducted survey in the United States and cover about 500,000 participants each year. The data is publicly available and the survey is conducted by the CDC. The survey includes non-institutionalized US adults aged about 18 years old, and the survey uses phone calls to contact the participants. Participants are selected through complex sampling methods, and survey weights and clustering are used. Besides, specific measures are used to minimize non-response selection and misclassification bias. Please, next one. This slide shows the study population. The whole number responding to the BRFSS 2021 to 2023 was about 1,300,000 individuals. After excluding participants based on the study exclusion criteria, including missing diabetes data, history of prediabetes or gestational diabetes, and negative diabetes history, the final study population consisted of 178,560 individuals. Please, next one. As mentioned earlier, general health was one of the outcome variables in this study. In the BRFSS, general health is evaluated in a self-reported manner. Participants are asked about how they feel about their own general health and how they are satisfied with their own general health, with possible answers ranging from excellent to poor. In this study, we have considered excellent, very good, good answers as favorable and fair, and poor answers as unfavorable general health. Healthcare access is assessed through 3 measures in BRFSS. At the time since last checkup, having personal healthcare provider, and any experience of healthcare non-affordability within the past year. Similar to general health, these measures are also self-reported. Next one, please. Yeah, next one. Thank you. All statistical analysis and figure generation was performed in R using survey-specific package. Missing data was addressed through imputation with the mice package using the random forest and iterative imputation methods. All analyses were conducted using weighted data, and all rates, means, odds ratio, confidence intervals are reported in their weighted format. Rye-Scott chi-square test was used for comparing categorical variable across study groups, and independent t-test was used for comparing quantitative variables. Age, sex, race-wise multivariate logistic regression models were used to assess the association between health insurance coverage, and outcome variables. All models were adjusted for available confounding factors, including demographic, social determinant of health, and comorbidities. Next one, please. As mentioned earlier, the general study population consisted of about 172,000 individuals who had a positive history of diabetes. Among this population, about 300 did not have health insurance. Comparing insured and uninsured participants showed that those with health insurance were older, had higher education and income, and were more likely to be married, non-Hispanic, white, or Black, and unemployed. Moreover, comorbidities were more common among those with health insurance. On the other hand, Hispanics were more likely to lack health insurance compared to non-Hispanics. Please, next one. These figures show the general health and healthcare access in the study population based on their health insurance coverage. As expected, individuals with health insurance had better healthcare access. They had more routine checkups. They were more likely to have personal healthcare provider, and they were less likely to experience healthcare non-affordability. Besides favorable general health, excellent, very good, and good were more common among those with health insurance. Next one, please. This figure is the main finding of this study. It shows the results of logistic regression models assessing the association between health insurance and study outcomes in each age, sex, and race groups. In fact, we want to compare the magnitude of this positive association across different age, sex, and race groups. Across age groups, the association of health insurance with general health, routine annual checkup, and healthcare non-affordability was most significant in the above 75-year-old group. On the other hand, this group had the least significant association between health insurance and personal healthcare provider. In comparison, the strongest association with having a personal healthcare provider was seen in the 65 to 74-year group. Across sex group, no significant difference was found regarding any of the outcome variable. Across race group, Hispanic had the lowest association between health insurance and healthcare access measures. This is in contrast to the initial finding that Hispanic had the lower health insurance coverage compared to other groups. The difference in association between health insurance and general health was minor. Besides, non-Hispanic Blacks showed a stronger association with missing annual checkups compared to Hispanics. Please, next one. This slide shows the type of health insurance across different age, sex, race group, like the Medicare, Medicaid, employer provided. I just skip it due to the time. Please, next one. And this, in this figure, we show the lack of health insurance coverage across the US states. You can see that most states with lower health insurance coverage are located in the South and Southwest. And countries that have the higher health insurance coverage are located in the North and Northeast. But these results are not adjusted to the population features like age, sex, and race compositions, and only demonstrate the general health insurance coverage status in each state. Please, next one. Our findings confirms that health insurance coverage is associated with significant better general health and improved healthcare access and affordability for patients with diabetes. However, our study goes beyond this obvious link between health insurance and better outcomes by identifying which uninsured age, sex, and race group are most at risk. Therefore, the findings of this study provide targeted insights for policymakers and healthcare providers to address disparities in healthcare access and outcomes. Thank you for your attention.
Thank you, Dr. Gambari, for interesting presentation. If there are any questions or comments, Dr. Gambari? It seems that, yes, Dr. Saidi, please go ahead.
Yeah, I think thanks for your nice presentation. I think this is a very actually important topic when it comes to public health and policymakers. But I have one question, if you're in Tabriz, what interests you to do this study and how did you get this data from US?
Actually, I had a plan to immigrate to the United States, but due to visa issue and travel ban, I couldn't get my visa. And I was actually getting ready for the immigration and working on the US health. And BRFSS is a publicly available data set. So I found this data set and I reviewed it. It has different variables. And by checking the variables, it just came up to my mind that I can work on it, but my immigration plan has stopped and I'm in Iran, but I worked on this topic.
Okay. Well, this is very interesting study. I raised a lot of, is gonna, I don't know, I think we don't have time to get into that, but there's a lot of, political discussions in the US, especially you showed that the states that have, lowest number of coverage, these are all states in South US, are all call it red states. And but
Yes,
there's a lot of political debate in US about these issues that unfortunately I don't think we have time to get into that.
Thank you very much, Dr. Mirsaidi. You have your hands up. Please go ahead.
Dr. Shukouamiri, can I have a small comment?
Yes, after Dr. Mirsaidi.
Sure.
Thank you.
با درود خانم دکتر. I really enjoy your talk and data that you work on it. As a person that's been working on disparities in the United States in the last 20 years, one thing I can share with you, the problem is not race. The race is not main driver for the differences. Low socioeconomic class is the issue. So nowadays, I don't talk about disparities in the term of Hispanic or African American, but we can find it out two factors. One, what is socioeconomic of the group that we are talking about? And second one, genetic susceptibilities. But I enjoy it, and your English is amazing. I couldn't imagine that you live in Iran.
Thank you very much.
Thank you, Dr. Mirsaidi. Dr. Nezakatgoo, go ahead, please.
I just wanted to echo and resonate the same comment that was given before me. I truly praise you for what you have done. I think this is a significant and important study for United States, and I think by performing and completing such an excellent, huge study, you definitely deserve to have a kind of lawyer, even through PAMA, to help you to come to this country and shine over here, because people like you do not belong just for one place. You deserve to have your impact and your knowledge and your talent to be given the opportunity to do more. This is my very humble opinion, and I think that PAMA may help you to somehow facilitate your process of immigration that is blocked, unfortunately.
Thank you very much. I hope I can find a way.
Sure, it was excellent.
Thank you, Dr. Nezakatgoo, for your suggestion. Dr. Amiri, you are on. Please unmute yourself.
I just want to make Dr. Ghambari not be so unhappy, because, as you know, I have contact with several people like you from Iran, that they were ready to get their green card, and they are wonderful, scientifically minded people who will contribute to the situation of science and medicine in the United States. And unfortunately, by the current government, it stopped suddenly. One of them asked me, what shall I do? I said that never give up and stay while you are there. Continue to do your good work, publish more, rather than sitting and worrying. Oh, I have failed. No. I tell them my story that I waited 13 years in Denmark, waiting to come to United States, and finally happened. I hope that it will not last 13 years for you, but it will change. I can promise you it will change. And meanwhile, make yourself stronger, doing more research, that you see that there you have access even to the United States data. Do your work, be stronger, and hopefully you will end up here.
Thank you for your advice.
Any more questions to Dr. Ghambari? We all wish her the best, and we hope that she can achieve her goals as soon as possible in the near future. And we in PAMA, we have one of our mission to help anybody we can help. Thank you. The next presentation would be by Dr. Mir Saidi. Dr. Saidi, please.
The next presentation is about a good friend of mine, Dr. Mir Saidi. Dr. Mir Saidi is a professor of medicine and chief of pulmonary critical care at University of Florida. And he's going to talk to us about microplastics and lung health, an emerging concern. Dr. Mir Saidi, thank you.
درود به همه عزیزان and thank you very much for inviting me for this great webinar. My topic that I'm interested to talk today is related to microplastics and lung. I think very emerging concern for many of us, and I'm sure that you heard concerns at this point, how we can learn more, and that's gonna be whole aim for my presentation today. Next slide, please. I have no conflict of interest about this presentation. Next one. Learning objectives for this talk divided to understanding source of exposure, review evidence on lung deposition of microplastics, explore biologic or mechanism underlying after exposure, and identifying risk gaps that are exist at this point. Next one. So what are microplastics? Let's start with definition as the first place, and understanding that plastic particles, they are so small, tiny right now almost everywhere, and size matters for their definition. Although this definition is not perfect in any term at this point, and we adopted from other particle matters, particularly dust matters, that's, I'm not sure 100% I agree with that at this point, but based on definition, what we call as microplastics means that every particles with plastic with the size less than 5 micron, and then if it is more than 25, call it macroplastics, and mesoplastics, something between them. And the source basically is almost everything. Whatever that we produce and use it and discard it in community, in environment, in oceans, on air, you can find out we're gonna have microplastics. And there is no really any place around our planet that you cannot find microplastics. The picture that I put here basically generated by our lab, and this is what we got from lung people without any underlying conditions. Next one, please. All right, so why we are defining based on 1 to 5, 1 microns to 5 millimeter, and then microns that I said for the 10 microns is my major concern. Basically, we are talking about the size can get inside the lung and end or terminal bronchi, as well as alveoli. And the size, whenever you're talking about less than 1 micron, you're talking about nanoparticles or nanoplastics that they can go and get into blood system and circulate for entire body. That is major concern that we have in many conditions at this point. Next one. So here you can find it out in the bottom. I cannot really make closer and show you, but you can find it out that we have 4 different pictures, some of them needle shape that is number D, or that microplastics that usually can go with airflow to the terminal, even with a good length and the size. And then some others, they are very cubic shape, and those they are not really getting end except the size is very tiny. But another very important and major reason for this slide is we have primary and secondary microplastics. And what secondary means? Whenever that in the environment, we just throw out our container of water, that plastic gradually is going to be making so small, tiny particles that going to get inside the body that a little bit later on, I'm going to show you those pictures too. Next one, please. What is magnitude of the problem? Everything in medicine, we talk about magnitude of the issue. Here is unbelievable high. At this point, every year we produce 46 million tons of metric tons of microplastics. That expectation for 2050 or projection is going to be more than double and into 1.1 billion metric tons, and all of them going to be environment. So basically what we are doing at this point, I'm not sure that we understand magnitude of the danger that we are facing with. Next one. So how that works and how that's going to reach the lung? Is there any evidence that we inhale them? Yeah, there are papers that you can find out. I cited for you over there, and you can see that every year we get, as average, 22 million microplastics inside of a lung. That means huge number of microplastics. Air, almost every part in United States, every part in Europe that the studying done, we can find out microplastics on air. And as average is almost 5,700 particles per cubic meter air that we are breathing in. And source, basically everything. Many synthetic, particularly clothes that we have and fibers produced every day in our houses, that probably concentration is higher than what we're going to get from outside. Next one. And it's not just lung. Microplastics can be ingested. We can get inside our GI system from different sources. Fish that everyone believes is a great source and healthy food, actually at this point is one of the source for major microplastics that you can get inside your GI. Salt and drinking waters, particularly that we want to be picky and every single one get a plastic container with water, you are getting a lot of those microplastics inside your GI. And respiratory, obviously, as we discussed, microplastics and different sizes, even macroplastics getting inside our lungs. And even for people that we are using for cosmetic and skin care, microplastics getting inside and going to be absorbed in the body. Next one, please. Inside the lung, base of information for particulate matters, we learn that whenever that size is more than 10 micron, going to stay in the upper or large airways. Although this is true for dust, for microplastic is not true, and I'm going to show you some pictures later on. The size, whenever reach to less than 10, we believe that going to get in bronchial tree, particularly reaching to bronchioles on a small bronchial tubes there. And in alveoli, whenever that we are talking about less than 1 micron, then it's going to change in circulation and entire body going to be actually engaged with that. new study published last year in New England Journal showing that almost more than 60% of atriums or any atherosclerosis in carotid artery being actually contaminated with microplastics. Microplastics in brain, in vascular, in the heart is a major concern at this point. Another one. What determines, what factors going to dictate that what part of the lung those microplastics going to sit? Main difference between microplastics with other particulate matters actually sitting in the top one, properties. So plastic is actually needle shaped, is very tiny in diameter, in length is bigger, but in the same time is very light. So airflow just move them in the end part of the lung and damage it, that for other particles, we don't have that property. Anatomy in the lung is important. Any disformity in the chest cavity matters, and health status, underlying condition like COPD, bronchiectasis, asthma matters, and breathing pattern actually is another factor. Some people that breathing from nose to mouth, they have different concentration of microplastics inside lungs. Next one. So whatever that this position gonna happen, how that gonna affect the different barriers in the lung as well as in the brain and others is very important topic. Just I want to bring this question for you that we need to think about, and in few other slides, I'm gonna a little bit dig it more. Next one. Another problem that we do have with microplastics and particulate matters in general is Trojan horse mechanism. Means what? Means that whenever they are flying on air or water, they can absorb chemicals and they can absorb viruses, bacteria, fungi. And after that, gonna just stay in the lung and stay for such a long time and make it a release of toxins and infection cause on it. Next one. When we are talking about microplastics, literally at this point, we don't have that many known. We can detect maybe 6, 7 of them nicely, like PE, like PP, like PS or PET, but many of those cannot be detected. For the first study that we have done, we found it out in the lung, 46 different types of microplastics that many of them we could not recognize and detect it, that what's going to be chemical structure of it. Next one. Interaction, how that going to happen? Oh, at this point, in vitro study showing that microplastics can get into epithelial cells, macrophages, and activate inflammatory response on it. Looks like that there are some evidence of DNA damage after happening and exposure of those microplastics. Because of time, I don't want to go in detail, but at least understanding that interaction between microplastics and epithelial cells and immune cells is documented at this point. Next one. Oxidative stress and inflammatory cascade is a part of what we are talking about. ROS generation and first part of cytokine production, starting from epithelial cells, is something that we can talk about. And then next step is chronic inflammation that can cause in chronic lung disease. Next one. Here you can see kind of graphic how immune cells, alveolar macrophages, epithelial cells can be engaged, and how really different parts of inflammatory response, even in vivo, a small animal, being studied and confirmed that basically is associated with a different inflammatory response on it. Next one. So besides of asthma exacerbation and COPD exacerbation and progression, we have pulmonary fibrosis that is a big concern for microplastics, particularly in a specialty that I do work. And lung cancer is what for that. We'll a little bit work on it that I would be more than happy to share unpublished data on this. Next one. PFTs or lung function can be affected. As we discussed, any change in bronchial tree or interstitial lung disease can change our PFTs. That is obstructive or restrictive defect in different type of severity of condition. Next one. The question is, if you have microplastic in lungs, how long gonna take time to end up to poor outcome? Usually subclinical phase is gonna take almost 10 years. And then between 10 and 20, you have early pathology or physiopathology changes. And then after 20 years, you're gonna have significant presentation, including cancer and interstitial lung disease. Next one. High risk. Who is high risk in this? Obviously, like many type of environmental conditions, we are concerned about pediatrics, elderly population, and those that they have underlying condition in the lung and other organs. Next one. People that been working in industries that a lot of exposure with microplastics is going to happen. Obviously, there are another group that's significantly exposed as occupational lung disease. Next one. We don't know many things about microplastics and effect on health. Even we don't know that we don't know. There are so many unknown regarding how that's going to affect, how going to be outcome, and what we need to do for those microparticles inside of a lung and how we can resolve them. Many challenges and limitations at this point that we are facing with. Next one. As I mentioned, in vitro studies, animal studies, we have some human biomonitoring in occupational medicine and big epidemiologic research in the term of those patients that work in those companies for others. Next one. Hossein John, I'm done with my time. All right. So
yes, please. We are at the end. A few more minutes, we are done with yours. So 1 or 2 minutes, that would be great.
And I love that. Thank you for letting me know. Go another one, just show you one, not here, next one. So lung cancer and microplastic, this is what for that our team done. Go next one. We isolated from 34 lung tissue samples, all of them with microplastics. And now you can see it, the real one, and the number F is the one that you can see secondary microplastics from environment inside the lung. And next one. And when we compare it between normal and cancer patients, we find it out that those patients with lung cancer, they have higher concentration of microplastics compared to control persons. Next one. And thank you very much.
Thank you so much, Dr. Mirsaidi, for finishing on time. And if there are any questions, please go ahead. It seems Dr. Amiri has his hands up. Go ahead, please. Please unmute yourself.
Participant. Okay. Thank you so much for sharing these bad news, really bad news with us. And of course, for the GI part of it, there is an outlet for that. I am not sure that how many of the microplastics are absorbed in the body or will be excreted. But in the lung, it's trapped. If it's not coughed up, it's trapped. And since we know that there is no end in the life of the plastics, so they will stay forever. And that is really alarming. So the solution would be to remove this from our life, which I know that is a big political issue and it may be difficult, but these type of talks and the publications and the news should bring to the attention of everybody that we are trying to do something so hurt ourselves. I mean, this will end up with cancer. This will end up with many problems with the lung diseases that may not be cancer, but may be worse than cancer, crippling the patient. So it's a huge issue that you shared. I appreciate that one. Thank you so much.
Thank you.
Thank you very much. Any more questions or comments? Okay. Thank you very much, Dr. Mirsaidi, for very interesting topics. And then we are now ready to go to the next one. And after this presentation, we are going to have a 15 minutes break. So Dr. Saidi, please present Dr. Frouzan.
Yeah, next presenter is Sam Frouzan. Sam Frouzan is a junior college student, and when he was a high school student, actually did work with us, and and he's going to talk about the longitudinal analysis of pancreas transplant outcome in U.S. over the past 20 years.
Thank you, Dr. Saidi. Good afternoon, everyone. Yes, my name is Sam Fourzan, and I'm excited to present our research about a longitudinal analysis of pancreas transplantation outcomes in the USA over the past 20 years. This work was conducted at SUNY Upstate Medical University with Dr. Mahmoud Reza Moin and Dr. Reza Saidi. This talk will examine trends in pancreas transplantation outcomes in the United States over the last 2 decades. Next slide, please. Before we get into the bulk of the study, I wanted to provide a little bit of background. Pancreas transplantation has been performed in the United States since the 1960s, and significant growth followed when the Organ Procurement and Transplantation Network was established in 1988. The number of procedures each year has varied, and the 3 main types of pancreas transplantations are 1. Simultaneous kidney pancreas transplantation, which is when transplantation occurs when a patient receives both organs from the same donor in one surgery. 2. Pancreas after kidney transplantation, which involves a patient who already has a kidney transplant and later receives a pancreas transplant. And lastly, 3. Pancreas transplantation alone, which serves patients with brittle diabetes and preserved kidney function. A clear understanding of outcomes across time and across these different procedures is needed, and a longitudinal analysis over 2 decades assists clinicians and patients in evaluating benefits. The findings inform decisions about organ allocation and surgical practice. Next slide, please. As for how the study was conducted, we conducted a retrospective registry analysis using data from the Organ Procurement and Transplantation Network, also known in its abbreviated form as OPTN, and the United Network for Organ Sharing, UNOS. The dataset includes all pancreas transplantations performed in the United States between January 2001 and December 2020. We excluded pediatric patients, recipients under 18 years of age and individuals with a prior history of pancreas transplantation, and then we divided the study population into 2 time periods. One was January 2001 to December 2010, and the second was January 2011 to December 2020. We measured survival outcomes and graft success rates at 5 years after transplantation, and we examined simultaneous kidney pancreas transplants, pancreas after kidney transplants, and pancreas transplants alone as separate groups. Next slide, please. The primary outcome measured differences in graft success and patient survival between the 2 time periods. We defined graft failure as removal of the transplanted pancreas or re-registration for a pancreas transplant. We also classified registration for an islet transplant after a pancreas transplant, insulin use of 0.5 units per kilogram per day or more for at least 90 consecutive days, or recipient death as graft failure. We used 5-year outcomes to evaluate long-term success. Next slide, please. After applying the exclusion criteria, we analyzed data from 21,561 adult patients. Simultaneous kidney pancreas transplants made up 16,359 cases, which represented 75.9% of the cohort. Pancreas after kidney transplants accounted for 2,951 cases, or 13.7%, and pancreas transplantation alone included 2,251 cases, or 10.4%. Some baseline characteristics across the groups were similar in age, sex distribution, and comorbidities. The one notable difference was the hospital length of stay following transplantation. Patients who received a pancreas transplant alone spent an average of 18 days in the hospital. Simultaneous kidney pancreas recipients stayed 12 days on average, and pancreas after kidney recipients stayed 9 days on average. These differences were most likely due to post-operative care complexity and complications specific to each procedure. Next slide, please. So the overall 5-year allograft survival rate was 74.8% for the simultaneous kidney pancreas group, 58.8% for the pancreas after kidney group, and 54.4% for the pancreas alone group. To provide greater detail, we divided the cohort into 2 periods, 2000 to 2010 and 2011 to 2020, and we observed improvements in allograft survival over time for pancreas after kidney transplants. The allograft survival rate for pancreas after kidney transplants increased from 56.9% in the earlier period to 66.4% in the later period. The overall 5-year patient survival rates were more comparable among the groups, with the simultaneous kidney pancreas group demonstrating slightly better outcomes. And this suggests progress in surgical technique, immunosuppressive regimens, and perioperative care. Next slide, please. In here, figure 1 shows Kaplan-Meier curves for graft survival among the 3 transplant types. The top graph compares all groups, while the bottom graph shows separate curves for the 2 time periods, and the blue line represents simultaneous kidney pancreas graft survival. The pink line represents pancreas after kidney graft survival, and the red represents pancreas alone graft survival. The survival curves demonstrate superior long-term viability for simultaneous kidney pancreas grafts. Pancreas after kidney graft survival improved significantly in the 2011 to 2020 period, which narrowed the gap with simultaneous kidney pancreas graft survival. Pancreas alone graft survival remained consistently lower, and these curves highlighted progress in pancreas after kidney transplants and persistent challenges in isolated pancreas transplants. Next slide, please. In figure 2, it represents patient survival curves and a table summarizing 5-year survival rates by transplant type and era. Across all groups, patient survival shows a gradual decline over 5 years, with the simultaneous kidney pancreas group maintaining slightly higher survival. The table on the right indicates the 5-year patient survival rate for simultaneous kidney pancreas recipients increased from 72% in 2001 to 2010 to 78.6% in 2011 to 2020. For pancreas after kidney recipients, 5-year survival improved from 56.9% to 66.4%. And for pancreas alone recipients, 5-year survival improved from 52.7% to 58.4%. These data confirm improved outcomes over time, especially for pancreas after kidney transplant. Better patient selection, improved perioperative management, and advances in immunosuppression were all likely contributions. Next slide, please. Our analysis demonstrates pancreas transplantation provides meaningful long-term graft and patient survival in the United States. Simultaneous kidney pancreas transplantation remains the optimal procedure for many patients, providing the highest 5-year graft survival. Some improvements in pancreas after kidney and pancreas alone transplant outcomes provide viable alternatives to reduce waiting times and expand access, and these procedures help address donors, recipient imbalances, expand the donor pool, and improve quality of life for patients with severe diabetes and related complications. Ongoing refinement of surgical techniques, immunosuppressive therapy, and post-operative care will further enhance outcomes. These findings support continued use and expansion of pancreas transplantation as a life-changing therapy for selected patients. Next slide, please. A few limitations should be acknowledged. First, the study uses retrospective registry data, which limits control over confounding variables and includes incomplete or misclassified data. Second, some patient records lacked key data points or were misclassified, resulting in omission of certain cases from the analysis, and missing data might skew estimates of patient survival or graft survival. Some future prospective studies with comprehensive data collection will help clarify our outcomes further. Next slide, please. Thank you all for your time and for your attention, and I'd be happy to answer any questions.
Thank you very much, Dr. Fouzan, for your nice presentation. And if you have any question or comment to Dr. Fouzan, please raise your hand. Dr. Shukwu Amiri, go ahead, please.
The only difference between pancreas availability and the other organ is that that's the only organ which is underutilized. We have more pancreas to be used than it is used. In liver, kidney, lung, and heart, we have not enough organs. But in pancreas, we have more than enough, but we are not using, and that has been the debate in the big societies of the transplantation to see how it should be solved. And the reason that many people are not aware of pancreas transplant, there are patients who coming to me that say, oh, is there a pancreas transplant these days? I said, we have been doing it for 30, 40 years. So people are not aware of it. And that, I think, should be more educated people. Many people come only for kidney transplant. And we see that they need a pancreas also, we tell them. So they are not referred for this one. And there are much more pancreas available that the centers are not using it. Maybe they don't have enough patient for that, or they are not that familiar with the pancreas transplantation. In the majority of the fellowships, Dr. Saidi can tell you that they have more stress on liver and kidney. Pancreas is not that well trained surgeons. So these are the contributing factors that we do not have so many pancreas transplantation. Thank you.
Thank you so much.
Thank you.
Dr.
I
just wanted to
have a Dr. Nazakat, do you have a comment?
I agree with you. I think that one of the reasons that there is a decreasing trend in utilization of potentially usable pancreas pancreatic organs from donors is lack of support by administration and the business, aspect of the practice of transplantation. Unfortunately, most centers look at the entire practice of transplantation purely from business standpoint, and that is very important issue that should be rediscussed and re-explored and brought more attention to this, incentives. I agree with you that current fellows in transplantation are not getting enough training for pancreas transplantation. And as you have seen, every year we have decreasing number of transplant centers that they are performing pancreas transplantation anymore, because it is not, there is no adequate numbers of pancreas transplant done by each center, and also they don't have enough support by administration because they think that it is not cost effective and they're not benefiting from pancreas transplantation. This is sad, but this is a reality. I don't know how we can address that, but this is an issue should be studied scientifically, and politicians should be aware of this, and regulation should be changed about that.
As I mentioned, the best evidence is that no treatment is giving the hemoglobin A1C to a normal level like a functioning pancreas. So a functioning pancreas is good, but the medical industry is involved with all those medications that coming to the market every day. They are trying to push that direction, and that hopefully will get better.
Thank you very much. I have a question to you, Dr. Shukran Miri. You mentioned that there are sufficient availability of pancreas for transplantation compared to the other organs. Can you please elaborate on that? How could it be more available, pancreas for transplantation?
Because they are not using it. There are not so many centers that they are doing pancreas transplant. There are few centers. The majority of almost all centers in United States, they do kidney transplant. The majority doing liver transplant, but not so many doing pancreas transplant. And so, and when you do not have enough patient for that, so you will be super selective and only the top good quality organs go for transplant. I mean, you can use other pancreas for transplant, that people don't do that. That's the reason.
Thank you. Thank you very much. If there are any more questions or comment to Dr. Fruzan.
Yeah, I want to make a comment. I think Dr. Nezakat Gu and Dr. Amiri said it well. You know, this is, you know, a matter of healthcare policy, as Dr. Kambari was pointed out. And despite the fact that in the past 20 years, the outcome of pancreas transplant is getting better and better, but you see the number of pancreas transplants going down. I think that's because, as Dr. You know, Nezakat pointed out, there is not much support for that. I think that's very important, you know, that as a transplant community, we lobby for this and make sure that other programs have, you know, trained adequate fellows, because that's one of the concern. There is a requirement that you have to perform certain number of pancreas transplant to basically, as a fellow, then you can, as attending, you know, be certified to do pancreas transplant. And those, you know, numbers, 2/3 of the transplant fellowship in this country cannot provide those numbers. You know, that's the thing. I think we have to lobby and, you know, make sure that we get enough support. I try actually very hard to gain, you know, support through UNOS, but even pancreas committee in UNOS or MPSA in UNOS is not willing to support that. Actually, Martina and I wrote a paper about this that's going to hopefully published in Progress in Transplantation, that, you know, the current requirements that they have right now is going to make it very difficult for the patient to stay, you know, active and continue this kind of work, despite the fact that there's good data, as Sam showed, that, you know, the results get better and better. Unfortunately, because of lack of support and lack of appropriate health policy in the US, the number of pancreas transplants going down.
Thank you very much. Any more questions or comments? If not, I would like make a notification here that if anybody of our participants who are interested in applying for CME credit, please send an email to us at info@pama.ngo, or you can also visit our website as pama.ngo. Please make attention that we don't have pama.com or .edu or .gov, but we have pama.ngo, which stands for non-governmental organization. And by this, we have reached our time for a 15 minutes break. So we end the session at this moment, and we resume our session again at 3 o'clock Eastern time. So 15 minutes from now. Thank you very much. Okay, so it's 3 o'clock, and we are going to start the last session of today, Sunday, 14th of September. And we are waiting for the next speaker, Dr. Amir Reza Ehsani. And then we are preparing his presentation in a few seconds. Dr. Saidi, please introduce Dr. Ehsani, please. Thank you.
Okay, I think welcome back. Our next presenter is the Dr. Ehsani. who's I think a surgery resident at the LSU, and he's going to talk about nervous intermediate sectioning for treatment of geniculate neuralgia.
Some correction, he is not in LSU, he is in Willis-Knighton.
Oh, okay. In Shreveport.
Shreveport, yeah.
Good afternoon, everyone. I'm Amir Reza Sani, and this is a retrospective study done at University of Stanford. Next slide, please. So to talk about geniculate neuralgia, it is defined as a rare facial pain syndrome. It is also termed as nervous intermediate neuralgia, and we know it as NI neuralgia. So it's a result from irritation or compression of the nervous intermediate nerve, which is a branch of facial nerve. If you can take a look at the picture, you can see the geniculate ganglion, and then after that, you have a branch off of the facial nerve number 7, and you can see the NI nerve over there. The function of this nerve is taste perception. It's tear and saliva production, nasal and palatal mucus secretion, and it can also kind of provide the sensory innervation of the external ear canal. Next. But we're facing a lot of challenges in terms of diagnosis and treatment of this type of neuralgia. One important factor is the significant symptom overlap for this type of neuralgia, because we have trigeminal neuralgia, which is involvement of cranial nerve number 5, and then we have glossopharyngeal neuralgia, which is number 9. And also the main issue is the rarity of this kind of condition, because from 1968 to 2013, only 50 reports were published, and even fewer than 150 document cases were kind of talked about since 1932 to 2012. And also the precise pathophysiology behind this irritation and compression is not well recognized through the decades of investigation. Next. To take a look at the treatment algorithm, we think about the geniculate neuralgia, we always start with the pharmacological management. So you go with your anticonvulsant treatment, you go with sodium channel blockers, and then if that's not helpful, you go for your second line, which is going to be minimal invasive surgeries like local nerve blocks, botulinum toxin. And if those are not covering the pain, you can go further and go for the surgical management of the patient. Usually, we don't section or cut the NI nerve as a standard of practice. And sometimes we do microvascular compression when there is a vasculature involvement for our neuralgias. So this study evaluates a consecutive series of patients with geniculate neuralgia who had craniotomy with NI sectioning to assess the safety and efficacy of the outcome. Next. For the surgical approaches, we have different approaches for our neuralgias. We have middle fossa approach, we have translabyrinthine approach, and we have retrosigmoid approach. The gold standard for this type of neuralgia is the retrosigmoid because of the a better exposure to the CP angle, kind of direct visualization to cranial nerve 7, 8, and 9. And even sometimes after a little bit of bone cutting, you can get better exposure to other cranial nerves too. So the design for our study was kind of checking all of our medical charts, and it's an IRB approved retrospective kind of analysis at Stanford University, 24-year of period since 2000 to 2024. And with the kind of median interval for assessment of the follow-up of patients for 120 postoperatively. And we use this Barlow Neurological Institute's pain intensity scale, which is a well-known scale for all of the neurology. Okay. Our kind of intervention for our patient was involving the sectioning of the NI nerve as our primary surgical intervention. And since most of our patients had concurrent geniculate neuralgia or like with trigeminal neuralgia or other kinds of neuralgia, we usually had to use microvascular decompression too. Next. If you look at the slide over here, you can see the pain score of all of our 45 patients. We had 45 patients and we did 47 procedures. So all of our patients came with a pain score of 5, which is a severe pain that is not going to be relieved with any sort of medication, and it is considered a refractory type of neuralgia. And after doing the latest follow-up for our patient, we showed that over 80% of our patient had significant pain improvement, and also almost around 70% of our patient had almost no pain, which is the pain score number 1, which showed that the 32 patients had no pain after the surgery. Majority of our patient had concurrent trigeminal neuralgia. Approximately over like 1/3 of the patients had both trigeminal neuralgia and glossopharyngeal neuralgia as well. Next. About the postoperative complication, which is a big kind of dilemma when it comes to NI-sectioning, because they believe in the literature that it can cause hearing loss in most of the cases, and they reported up to 60% of this complication. Permanent facial paralysis was reported around 20%. Permanent vestibular dysfunction and taste disturbances, those were among the complications that were most common after doing the NI-sectioning as well. But in our study, we showed that only 2 of our patients had hearing losses and 0 permanent facial paralysis, 1 permanent vestibular dysfunction, and 3 taste disturbances. So overall complication profile in our study demonstrated an acceptable risk-benefit ratio for this kind of procedure. Next. Okay, to compare this study with the prior literature, as we discussed, they are reported frequent side effects involving different cranial nerves, like cranial nerve 7 and 8 as most common complication. But in our study, we avoided those kind of complications. We suggested that it is a safe and effective kind of approach to do NI-sectioning while you're operating on patients with neuralgia. Maybe it reflects the refinement of surgical technique at this institute. And maybe you can kind of correlate this outcome with those microvascular decompression of different cranial nerves. But it is kind of well known that this study is one of the largest sample size available in the literature to the current date. And we do believe that NI-sectioning represents a viable surgical option for those refractory geniculate neuralgias, and you can consider concurrent microvascular decompression of cranial nerve 5, 9, and 10 when the symptoms overlap. Next. The limitation for our study was the fact that this is an extreme rare condition with a small sample size that can limit our generalizability, and also the short medium follow-up. We just followed the patient. The medium follow-up was 122 days. So we may miss long-term recurrences and complications. We're looking forward to that. An overlap of different cranial neuralgias like trigeminal, as we discussed, can kind of obscure the view and complicates the diagnosis and interpretation of the pain relief and etc. Next. To conclude this study, this is one of the largest case series to date for NI-sectioning that performed, and it's a safe procedure with low permanent cranial nerve 7 and 8 morbidity, which was a big concern over decades. And this is an effective approach for pain relief, as we saw majority of our patients developed like pain relief, and at least 70% had like no pain after the surgery with short follow-up. We support NI-sectioning as a viable option for geniculate neuralgia treatment, but for sure, perspective and long-term studies needed. Next. These are my references, and thank you so much for your attention. I would be happy to answer any questions.
Thank you very much, Dr. Ehsani. If there are any questions or comments to Dr. Ehsani, Dr. Amiri, go ahead, please.
Thank you, Dr. Hassani, for presenting your great data. But actually, you said that it's very rare. It may not be that rare, but it is not coming to the medical attention. Actually, two of my close relatives are suffering from this one. I just wanted to know how many centers are doing this procedure, and it may be good that now you have so many cases, continue to observe them for longer period to see if the long-term effect also is as good as the shorter, even though it's not optimal. I mean, 70% improvement may not be as optimal as we would like to see, but comparing to what they suffer at this time, it may be a blessing. Thank you.
Thank you so much, Dr. Shugramiri. I do believe that's true because most of these patients with genicular neuralgia would be diagnosed as different types of neuralgia, like trigeminal neuralgia, and they address a different kind of cranial nerve. But currently, I do believe that this kind of procedure, NI sectioning per se, is going to be done at the University of Maryland and Johns Hopkins and Stanford. Most of the other institute will not go for that NI sectioning procedure. And I do think that we are working on the 10-year kind of interval for our follow-up. And the next kind of point is to go for 20-year to see how that affects in a long-term period. But thank you so much. That's a great thought. Yeah, for sure.
Thank you.
Is there any more questions or comment to Dr. Ehsani's presentation? Okay, so we are ready for the next presentation. Dr. Radin Anvari, Dr. Saidi.
Yeah, our next presenter is Dr. Radim Anvari from Drexel University in Philadelphia, who's going to talk about co-infection with severe acute syndrome coronavirus 2 and human coronavirus HK respiratory U1.
Thank you very much. Salam Bahamagi. I'm Radin Anvari, third-year medical student, Drexel University. Very honored to talk about this very interesting co-infection with two coronavirus families. Yeah, I hope it's very informative. Next slide, please. No financial or non-financial conflicts to disclose. Next slide. So a little bit of background about this case. This happened about an hour away from Philadelphia in a smaller community practice in Pennsylvania. We had a patient who was co-infected with two strains of coronavirus. One, the infamous SARS-CoV-2, which causes COVID-19. I'm sure we're all familiar. And a little less common coronavirus. It's called HQU1, first identified Hong Kong 2005. Causes common respiratory upper tract infections, so fever, cough, of course, you have some common symptoms with that. And what was interesting is this is a pretty rare co-infection, and very little is known about these two viruses being infected in a patient at the same time. Next slide, please. So like I said, this is in a smaller community practice. Our patient was an 85-year-old male. He had a past medical history, type 2 diabetes, atrial fibrillation, hyperlipidemia. He was a former smoker. This happened in early 2024. So this patient had their COVID-19 vaccines 4 years prior, which would be 2020. His presenting symptoms were a little bit unusual for upper respiratory viral infection. He was afebrile. He was complaining about recurrent falls, diarrhea, and a cough for a few days. And when he presented to us, he did have shortness of breath. And when we took the vitals, the main thing that jumped out was respiratory rate of 28. He was afebrile, normotensive, as you can see. And when a viral panel was done, we saw positive for both SARS-CoV-2 and the coronavirus HQU1. Next slide, please. So upon admission, in addition to having a co-infection of 2 coronavirus types, there was a superimposed bacterial pneumonia. We ended up doing supplemental oxygen. He was originally had an O2 sat of 89, which then improved to 92. In addition to that, we treated with remdesivir and dexamethasone, given his need for admission and possibly respiratory distress. And regarding the bacterial pneumonia, treated with ceftriaxone and doxycycline. One thing I do want to note is we did have to stop the remdesivir due to atrial flutter and bradycardia that developed. And this required an urgent ablation and pacemaker, which then required us to start medications for the pacemakers, apixaban and metoprolol. And another thing that complicated this hospital course was our patient complained about dysphagia and some delirium. So this added to his already prolonged stay and required gradual recovery with rehabilitation. Next slide, please. These were some laboratory data that we had from this patient. Not too much really jumps out. The main things I want to highlight here, his HbA1c was 82 on day 4. That's the only one we had, so doesn't seem like his diabetes was well controlled prior to admission. White blood cell count really just elevated on day 7. What was interesting is given the viral co-infection and superimposed bacterial pneumonia, and the fact that he was afebrile on admission, he didn't really have anything jumping out in terms of a very exacerbated immune response. This patient was overall pretty healthy, given his medical history, and we did see an elevated CRP. Next slide, please. So just kind of elaborating here, not only is this co-infection rare, just even having the HQU1 strain in the United States it's not common. It counts for about 1.6 of adult respiratory infections. And even when they are present in the United States, there has been more of an association with pediatric illnesses. It is a type of virus that is associated with pediatric febrile seizures. And the only other noted co-infection with these 2 strains of coronavirus was reported in 2020 during the early outbreak of the COVID-19 pandemic. A little bit different presentation there compared to our patient. That patient was a 34-year-old male who had classic symptoms of a viral upper respiratory tract infection, and they had an uneventful recovery. In contrast, our patient, who is much older and did have a more complicated past medical history, what I do want to draw is we did see more atypical symptoms, such as the recurrent falls and diarrhea, that we wouldn't really see with 2 not only coronaviruses, but just viruses in general at the same time. In addition to that, most co-infections with SARS-CoV-2 are actually bacterial from the literature, and that's usually due to prolonged hospital stays. Usually we see SARS-CoV-2 with either E. coli or Pseudomonas, especially in adult populations. So just having 2 viral co-infections, just not all that common. Next slide, please. So regarding the remdesivir, something I want to highlight here, it is known to have adverse effects on the cardiovascular system. There's no contraindication for giving remdesivir in a COVID-19 patient with AFib, but it is something that requires close monitoring since it does have a risk for cardiac arrhythmias, most notably QTc prolongation, which can lead to TDP, torsa de pont. But again, we did see a flutter in our case, which did prompt us to require ablation and eventually the implantation of a pacemaker. Next slide, please. So like I said, cautious use of remdesivir is something we recommend in a patient who is hospitalized, does have a history of AFib, and of course, any COVID-19 infection, especially with a co-infection that does require hospitalization, we do want to watch out for that. And another thing that I just want to highlight is, when we have these atypical presentations coming through the hospital, a thorough viral panel is something that we would emphasize. That just because that could trigger if you start thinking about, could this be superimposed with bacterial, viral, etc. So anytime we see those atypical symptoms, just be a little bit broad in our thinking in our differential diagnosis. Next slide, please. I just want to acknowledge our team at WellSpan Health in Pennsylvania that allowed for us to present this case. Next slide. And these are our references. Thank you very much.
Thank you very much, Dr. Anvari, for a nice presentation. If there are any questions or comments to Dr. Anvari's topic. It was very hot a few years ago when it started, and then all the treatment and result, thanks to all people who were actively engaged in the treatment and prevention of the disease. It seems you explained it very well, so there is no questions. So we are ready to go to the next presentation. Thank you very much, Dr. Anvari. So we are going to the next presentation by Dr. Mateen Muallim, who also has helped us today with the preparation of this conference with the PowerPoints and sharing the presentation. That everything went very smoothly without any time consuming for changing and sharing between the files. Dr. Saidi, would you please present Dr. Mateen Muallim? Thank you.
Yeah, I think the last presentation for the scientific portion of our webinar is by Dr. Mateen Muallim Shahri, who's currently a postdoc research fellow at SUNY Upstate, and he's going to talk about bridging the organ shortage gap, improve survival in live donor liver transplantation over 2 decades.
Hello, everyone. Thank you again for joining us in this first annual meeting, and thanks to my mentor, Dr. Zasaidi and Dr. Shukuhamiri. So this study is addressing the organ shortage gap for liver transplantation. We evaluate the survival and the outcome of the living donor liver transplant in the past 2 decades. This study is designed and conducted in SUNY Upstate Medical University by Dr. Zasaidi. So this study has no personal or financial conflict of interest or no source or funding used for this project. So if I want to say a background of this study, at first, as you know, liver transplantation, including both deceased donor liver transplantation, as we call it DDLT, and living donor liver transplantation, as we call it LDLT, has emerged a life-saving treatment for patients who are with end-stage liver diseases. Like hepatocellular carcinoma or acute liver failure or viral hepatitis or autoimmune hepatitis. As of June 2025, there are 105,583 individuals on the United States transplant waiting list, which including 9,000 of them waiting for liver transplants. While LDLT has been widely adopted in many countries, particularly in regions with limited access and underprivileged area, deceased donor organs, the outcomes in patients remain underexplored. Recent studies have demonstrated comparable superior long-term outcomes in the LDLT compared to deceased donor liver transplant, particularly when performed in centers with significant expertise and well-equipped facilities. In our study, we aim to address these gaps and comparing the surgical data from 2 distinct periods. The first period is from 2000 until 2010. We call it the first cohort, and the second one is 2011 until 2023. We call it the second cohort. So in this study, which is a retrospective study, we use the data from OPT and UNOS databases. We included living donor liver transplant that performed in the United States from January 2000 until May 2023 in these past 23 years. And a study, as I said, divided into two cohorts. Our recipients, our exclusion criteria was the recipients who passed away within 13 days of the operation, and they failed to follow up or receive this is donor liver transplant, and also the young individuals who were under 18 years old. So as of primary transplant indications, primary transplant indications, we first examined the distribution of primary liver failure etiologies among all recipients. As you can see, biliary disorders and viral hepatitis, which is acute or chronic, were the most frequent indications here, each including approximately 25% of cases. Alcohol-related disease accounted for 13.3% of primary liver failure etiologies. Non-alcoholic steatohepatitis, as we call it, NASH, but in the last 2 years, the term changed to MASH, metabolic associated steatohepatitis. For 10%, and hepatocellular carcinoma and other liver tumors for 9.2%, and metabolic and autoimmune disorders for 6.4%, and other causes of liver failure for 10.4% of the etiologies. So, so we compared the two periods by using a chi-square analysis with one Ferroni correction, and observed significant trends. HCC and the other tumors of liver transplant from 7.1 to 11.3%. Viral hepatitis declined from 34.4% to 50.9%. And as you can see, the NASH increased from 2.9 to 17.6%. As you know that during these past decades, the disease related to NASH increased, and that's why we can see these trends. And as you can see, on other failure etiologies decreased from 12.1 to 8.6%. And biliary disease, alcohol-related disease, and metabolic autoimmune disease did not meet the correct and significant threshold in our study. So, for the as a point of characteristics, we first go with the recipient characteristics. Recipients in first cohort were significant. In second cohort were significantly older than patients in first cohort, by mean age of 53 years old compared to 50. Recipient is in the more recent cohort had a slightly but significantly higher body mass index. The mean BMI increased from 26 to 27 approximately. This change is statistically significant, as we can see. The MELD score, which is the mean model for end-stage liver disease at transplant, was meaningfully higher in later period, as you can see, which is increased from 40 to 60. This increase, as you can see, is significant. For donor characteristics, the average age of living donor remained unchanged between two cohorts, as you can see here, and there was a significant shift in gender distribution of donors. That's very interesting because the proportion of female donors increased from 48 to 52 in the second cohort, while male donors decreased from 51 to 47. This change is significant and highlighting a meaningful shift toward the greater female participation. Like recipients, donor in later period also had a slightly higher mean BMI, increased from 26 to near 26.2. This difference, while small, is statistically significant. And in the last, the average cold ischemic time, the time that the graft spends cold outside of the body, appeared to decrease from 2.6 hours to 1.8 hours, which is, despite this decline, this change was not statistically significant. So in the matter of survivals for both patients and graft survival, we evaluated 1 year graft survival, and we saw that it increased from 80, as you can see in the left upper graph. As you can see, it increased from 85% in first cohort to 90% in second cohort, and 5 year graft survival improved from 70% to 78%. Likewise, in the right right upper graph, as you can see, 1 year patient survival increased from 92% in the earlier cohort to 94% in the later cohort. And 5 year graft survival, 5 year patient survival increased from 79 to 84%. We also analyzed the 5 year graft survival and patient survival for hepatocellular carcinoma and acute liver failure. We saw the interesting trends. Among HCC patients, 5 year graft survival improved from 58% in the earlier cohort, as you can see in the left bottom one, to 73% into later cohort with a meaningful change. And 5 year patient survival increased from 64% to 77%. For acute liver patients, acute liver failure patients, 5 year graft survival increased from 63 to 78 between the two cohorts. However, this improvement did not reach statistically significant, but the clinical outcome showed the improvement. And what stands out in the 5 year patient survival increased from 71% to 96%, with the difference approaching the statistically significant difference. So, in the matter of changes in the graft failure etiology, as you can see in this table, the primary disease recurrence, primary graft failure recurrence, which is not, which we assume it non-hepatitis, had the highest hazard ratio for graft loss, as you can see here, and decreased significantly from 70%, 113 cases in first cohort to 9%, only 20 cases in the between 2011 until 2023. In the etiology of vascular thrombosis, as you can see here, increased from 19%, 113 cases to 35%, and more than doubled the risk of graft failure. For primary graft failure, accounted for 21% of failure in both times period and remained a consistent challenge, which was significantly increased the risk of graft loss. For hepatitis recurrence, it showed a major improvement, dropping from 40%, which were 93 cases, to just 2%, only 6 cases, but yet remained significantly associated with graft failure. For chronic rejection, it declined from 5% to 2%, but did not show a statistically significant risk change. Biliary complications increased from 9% to 30% to 30%, but were not associated with graft loss. Infection remained relatively stable between two cohorts with no significant impact on the hazard. of graft loss, and accurate rejection rate from 3%, it means 20 cases, to 7%, it means 17 cases. That not significantly had an effect on the hazard of graft loss. So in summary, non-alcoholic steatohepatitis and hepatocellular carcinoma became more common reasons for transplant. Viral hepatitis declined. LDLT recipients are now slightly older with higher MELD scores and BMI. Vascular thrombosis is now a more common cause of graft failure and a serious one. And primary disease recurrence and hepatitis recurrence, although they are less frequent, but they are show the carry high risk. Acute rejection cases have increased slightly, but don't significantly impact long-term success, and infection and chronic rejection rated remained mostly stable. So in conclusion, living donor liver transplant showed a significantly improved patient and graft survival. Although improvement, especially in reducing hepatitis-related failures, LDLT success still needs better management of vascular complications, as I showed you, and for vascular complication and primary disease recurrence. Optimized donor recipient matching and tailored post-op care can make a real difference here. Our findings demonstrate a marked enhancement in outcomes over the study periods, underscoring the evolving success of LDLT in high-risk patients. Given the substantial gap between the demand for liver transplant and limited availability of donor organs, it's imperative that we direct our focus toward the living donor transplantation. And the profound improvement in outcome over the past decade highlight this potential for the living donor liver transplantation, and it improves the shortage of a gap between the demanding and existing the organ for transplantation. This result emphasizes the critical need for optimized patient selection and preoperative management to further advance transplant success. So this is my study. If you have any question, I'll be happy to answer.
Thank you very much, Dr. Mateen Muallim, for your nice presentation. If there are any questions or comments to Dr. Muallim, please go ahead. Dr. Amiri, you have your hands up.
Yes, thank you so much for presenting this data together with Dr. Saidi. As you know, the reason for living-related liver transplant in some societies more than the other is mainly cultural, and it's not because of the rules and regulations. There are countries like Egypt, like South Korea or Japan. They have not accepted the brain death criteria for whatever reason that we are not going to go through those ones. But those are the countries that they do more of the living-related liver transplant. Liver transplant from living donor is different from living-related transplant from a kidney or even a lung. You have two kidneys, and the risk of death of the donor is much less. And in the liver, any mistake can end up fatally with the donor. And of course, countries like United States, that there is so much control over what is happening there. So it's different from Egypt, for example, or Argentina. Because of my involvement from the beginning in living-related liver transplant. Actually, we were the third program in the world that we started the living-related liver transplant in Memphis. So I'm quite aware. I have been trained so many of them people. I know in Argentina, so many patients, donors have died. In Egypt and in India, and also they don't report. The reporting system, the transparency is different. In the nature of the patient population are different. In, for example, Korea, you don't have or in Japan, you don't have the issue that we have here, the obesity, the overweight. And for example, in Korea, sometimes they take 2 from 2 donors, left lateral segment, in order to decrease the the incidence of complication in the donor. In United States, it can never happen. Even for 1 donor, we have problem to convince the donor to donate, and we cannot get 2 donors for 1 recipient. So it's very complicated. And in all my talks to people that I have been dealing with the transplant, I have told them that try to use brain-dead donor. Now that we are expanding even with the use of perfusion machines, to use that one and limit those that will not be a candidate for transplant. For example, somebody with a cancer that will not be qualified for the liver transplant, and the family insists, no matter what, they want to save the life of that person. That's their choice. We have to respect that one, and we have to give to them the chance of living related liver. And these days, you know that the technology has advanced so much. They are doing the donor nephrectomy robotically, and is less invasive, and is done safely. But it should be under a strict protocol. Not everybody can do that one, and they should not, because any mortality will make the transplant system even more difficult to convince the donors to donate. So it's extremely important issue you talk, and I hope that those countries like Egypt and India and those, they will consider bringing the issue of brain death to their all the transplant in Egypt. Kidney have been doing for more than 50 years, is living related. Of course, you do not know who is donor they are selling and buying. There are a lot of ethical issues that we cannot compare those to what is happening in Europe and United States, that have really high standard of control. I mean, one death in New York, you saw that what happened to the living related donor. Over several years, it went down, and then gradually now it's coming up. So here, the rules and regulation are different, and which is very good, is respectful, but we have to encourage the other countries also to do more donor from brain death than living related. Thank you.
Yes, exactly. Thank you, Dr. Amir, for your comments.
Do we have more comments or questions to Dr. Mateen Moallem's presentation? If not, with your permission, I would like to say that we are approaching the end of our scientific session. And with the group permission, I would like to suggest that we hold a 5 minutes break, and then we can start the General Assembly session that we are going to talk about membership and future activities. And I would like everybody to participate in the general discussion, suggestion, and talk.
I would not like to just have
So,
two.
Dr. Said,
Yeah, I would like to have,
Dr. Saidi, you have your hands up. Please go ahead.
we have 2 housekeeping, comments. One, I would like to thank all the presenters for their excellent presentation and staying on time. I want to remind everyone that if you're interested to obtain CME, send us an email through info@pama.ngo. And also, we will actually look at all the scoring scoring for the Young Investigator Award, and then hopefully in a couple of days we announce the winners and send the email to everyone. But I will encourage also everybody to stay for General Assembly of PAMA to hear about PAMA's activities in last couple of years, and also the future direction of the organization.
Dr. Amir, you have some comments?
Yes, I also wanted to congratulate all the speakers, especially the younger ones, which made me proud that we have such a talented young generation among Iranian scholars in United States and in Iran, that it impressed me. As you saw, the majority of this scientific meeting was transplant oriented. And that's because of Dr. Saidi and me that we are in transplant. So our fellows and residents, they were more active. I would like to see a change in that for the next year. It should not be only transplant related. I would like you to inform your friends and colleagues who are in medicine doing research, send their research to the next year's scientific meeting and be involved more. We appreciate that one, and hopefully it may be 1 or 2 transplant. Rest of them will be non-transplant related. And hopefully we will get a successful meeting year after year, and we continue our monthly webinar. I'm sure you all know that Dr. Saidi is running a session for the how to get to residency in the United States, which 5 sessions of it has gone. We did not have in this weekend and the previous weekend because we were involved in other scientific activity, but it will resume again. And I hope that everybody will take advantage of that one. And you know that membership in PAMA is free for the student, resident, and fellows. Take advantage of that one. And by doing that, we hope that you really become interested in the mission of the YAMA. Why we are doing that one? We are doing for the sake of future Iranian that may want to come here and reach to their goals. So please be more involved. And later on in the assembly, I will announce other things that for the election, we will talk about that one. Thank you so much, everybody. And hopefully we can have a good general assembly also.
Thank you very much, Dr. Amiri. So we are going to have, now I can say that 7 minutes. I wanted to give 5 minutes, but now 7 minutes break. So we will start at 3:55 p.m. Thank you very much. I will pause the recording.
من موقعش هستش دیگه الان؟
بله بفرمایید.
با درود فراوان دوباره به تمام همکاران و دوستان عزیزمون جنرال اسمبلی رو شروع میکنیم. این اولین به اصطلاح نشست ما هستش که با برنامه ساینتیفیک شروع شد، ساینتیفیک پاما شروع شد و الان اجندا رو میبینین گذاشتن روی صحنه، همه اجندا رو میبینین و اول خواهش میکنم که در مورد ممبرشیپ و در مورد به اصطلاح وضع مالی پاما صحبت بشه. بعد دکتر سعیدی راجع به همین ساینتیفیک میتینگ صحبت کنن که زحمت کشیده بودن. من بهشون تبریک میگم که تونستن این برنامه رو به این خوبی به راه بندازن و very high quality scientific paper داشتیم و بعد خود من راجع به انتخابات آینده باتون صحبت کنم. بفرمایید راجع به ممبرشیپ. محمد شما راجع به ممبرشیپ میخواین صحبت کنی؟
راجع به تریژر ریپورت
صحبت کنی، فرق نمیکنه، هر دوش بالاخره باید صحبت بشه. بفرمایید.
اینا با هم وابسته هستن. در وهله اول تشکر میکنیم از تمام اعضایی که به اصطلاح حق عضویت خودشون رو پرداخت کردن و پاما رو ساپورت کردن در این 1 یا 2 سال گذشته. و در اینجا من خلاصه‌ای از گزارش مالی رو داریم و کسانی که به اصطلاح مواردی هم که دونیشن داشتیم. در این مدت ما 53 نفر پید ممبر داریم که شامل متین جان برگردیم به اسلاید قبلی، اسلاید تریجرر. بله، 53 نفر ممبر داریم که شامل پرکتیسینگ ممبر هستش، پرکتیسینگ فیزیشن، دنتیست، pharmacist and others, nurses and retired. Some of them they pay with full membership and some of them with a reduced membership که برای for example افراد ریتایرد و افرادی که فیزیشن نیستن. بعد نان ممبر داریم، به اصطلاح نان پید ممبر داریم که شامل رزیدنت ها، فلو ها، پست داک، استودنت ها هستش که پاما تصمیم گرفت که برای این افراد ممبرشیپ زیرو باشه در مدتی که اینها در دوران ترینینگ هستن و میرسن به قسمت پرکتیسینگ. در نتیجه ما حدود 118 ممبر نان پید داریم که شامل رزیدنت ها، فلو و پست داک ها میشن. در این مدت ما حدود $4,600 دونیشن دریافت کردیم که از دونرامون خیلی خیلی تشکر میکنیم و نامه‌های تشکر هم فرستادیم براشون و کسانی دیگری هم که اگر بخوان ساپورت بکنن و دونیت بکنن ما خیلی خیلی ممنون میشیم. مخارجی که ما داشتیم به علت این که در این مدت ما به صورت آنلاین کار کردیم، به هر حال خیلی از مخارجی که میتینگ های کلاسیک داشتن رو نداشتیم در نتیجه، ولی خب مخارج دیگه ای داشتیم از قبیل به اصطلاح رجیستریشن. از اون زمانی که ما پاما رو رجیستر کردیم به عنوان نان پروفیت نان گاورنمنتال ارگانیزیشن و وبسایتمون رو دیولپ کردیم، مینتین کردیم، برای ایمیلامون سرور گرفتیم و دومین گرفتیم. مخارج کلی در این مدت 2 سال حدوداً $5,000 شده. چرا من نوشتم الان $5,000 و دقیق نیست؟ برای اینکه یک سری از مخارج آنگوینگ هستش که در جریان هستش ولی در این حوالی میچرخه. با توجه به ارقام دریافت شده و مبالغ ممبرشیپ های کامل، نیمه کامل و به اصطلاح زیرو پیمنت ها، ما الان در حسابمون $14,317.87 بالانس داریم که میتونیم برای مخارجی که داریم و برنامه‌هایی که داریم استفاده کنیم و امیدوارم که بتونیم این مبلغ رو بیشتر کنیم که دست ما بازتر بشه برای برنامه‌های آینده و به اصطلاح ما تمام افراد رو انکارج میکنیم که ممبر بشن، به خصوص افرادی که قبل از رزیدنسی هستن که در اینجا ساپورت‌های خوبی میگیرن برای اطلاعات برای رزیدنسی، برای ریسرچ و افراد دیگه هم که جزء پرکتیسینگ افراد هستن. اینا رو هم انکارج کنیم که پزشکی قوی داشته باشیم. وقتی که میگم پزشکی شامل تمام گروه‌های هلت کیر از قبیل دندان پزشکی، داروسازی، فیزیکال تراپی و بقیه گروه‌هایی که در رابطه با درمان و به اصطلاح پیشگیری هستن. همه ویلکام هستن که به ما جوین کنن و ما رو ساپورت کنن که ما بتونیم به عنوان یک گروه بسیار قوی پزشکی در خارج کشور بتونیم فعالیت داشته باشیم و به امیدی که روزی هم به ایران برگردیم. اگر سوالی در این رابطه هستش متشکرم میشم. خب کسی سوالی کامنتی راجع به این گزارش؟
من سوالی نمیبینم، بنابراین اپروو میکنیم برنامه که شما پرزنت کردین در مورد تریجر ریپورت و کامباین هم کردین با ممبرشیپ. بنابراین هست میریم سر آقای دکتر سعیدی که ببینیم چند تا ابسترکت داشتیم چجوری بوده اینا، یه توضیحی در مورد این هم بدین. دکتر سعیدی میکروفونتون بسته است.
با تشکر همه دوستانی که تا اینجا صبر کردن. من میخوام 2 تا ریپورت بدم چون 2 تا کامیتی داریم ما در پاما که من مسئولش هستم، یکی ساینتیفیک کامیتی، یکی ممبرشیپ کامیتی. برای ساینتیفیک کامیتی فعالیتی که ما داشتیم این بود که ما بای مانتلی وبینارهایی داریم که شاید شما شرکت کردیم، ویکند ها هست، معمولا 1 ساعت هست که تا حالا ما بیش از 20 تا وبینار برگزار کردیم. یکیش هم همین مسئله انوال میتینگ بود که اولین انوال میتینگ پاما بود که ما در حدود فکر کنم بیش از 20 ابسترکت دریافت کردیم، ولی به علت محدودیت زمانی که بود فقط 20 تا ابسترکت رو انتخاب کردیم برای این وبینار که خوشبختانه به خوبی هم برگزار شد و ما 3 تا یانگ اینوستیگیتور اوارد هم داریم که به زودی اعلام میکنیم. برنامه‌های دیگه‌ای که ما در ساینتیفیک کامیونیتی داریم همونجوری که دیدین بیش از 2/3 ممبرای پاما افراد جونیور هستن که هنوز وارد بازار کار نشدن و ما برنامه‌های مختلفی از مثلا از اون ریسرچ سمینارهایی خواهیم داشت که ریسرچ به اونها یاد بدیم و برنامه‌های از این قبیل. در مورد منتورشیپ کامیتی ما سعی کردیم که افراد سینیور رو گرد هم بیاریم که بتونیم به افرادی که میخوان وارد رزیدنسی بشن در آمریکا یا واسه میخوان جاب بگیرن در آمریکا کمک بکنیم، ادوایز بدیم. برای در اون زمینه هم یک سری سمینارهایی رو اجرا کردیم تا حالا درباره ورود به رزیدنسی در آمریکا که تا حالا 5 موردش اجرا شده و ما فکر کنم 4 جلسه دیگه داریم که از 27 سپتامبر دوباره این جلسات رو ادامه میدیم. سعی داریم که یک برنامه‌های کوریر دیولپمنت هم درست بکنیم برای ممبرشیپ جوانمون که آشنا بشن با جاب اپورتونیتی های مختلف هلت کیر در آمریکا که بتونن چطوری کوریر خودشون رو حتی بعد از ورود به رزیدنسی ادامه بدن. در حال این برنامه‌ای هست که ما فکر کنم در ادامه سال 2025 و 2026 ادامه بدیم. اگه دوستانم موارد دیگه هستن که فکر میکنن احتیاج به کمک دارن یا احتیاج دارن برنامه‌های در این زمینه اجرا بشن، خوشحال میشم که ما تماس بگیرن. همونجوری که گفتیم ایمیل ما هست info@pama.ngo که میتونن با اون طریق با ما تماس بگیرن و ما در ارتباط باشن.
اگر سوالی برای دکتر سعیدی هست بفرمایید. اگر نه من خیلی سپاسگزارم از زحمت‌های شما. میریم سر قسمت آخر که خود من ریپورت میدم و این ریپورت پرزیدنت هستش که اولا من سپاسگزار هستم از تمام فاندینگ ممبرها که به صورت یک گروه کوچیک ما پاما رو راه انداختیم و تمام به اصطلاح زحمت‌ها روی چند نفر بیشتر نبوده که اینا همه این کارا رو کردن تا به اینجا رسوندنش. نوشتن بایلا، رجیستر کردن و راه انداختن وبینارها، سمینارهای مختلف و برنامه امروز و دیروز که بسیار بسیار موفق بود و ما سعی کردیم که برای بالا بردن ارزش این پاما مثل آنری ممبرای خیلی خیلی سطح بالا که 2 نفرش رو دیدین، دکتر علا و دکتر رستگار رو، و در آینده از دیگر به آنری ممبرامون رو خواهش خواهیم کرد که برنامه‌ای برای شما بذارن و سطح دانش و سطح تجربه پزشکی که اینا دارن که واقعا بی‌نظیر هست برای شما ارائه بدیم. برنامه‌ای که تا حالا بوده روی به اصطلاح پرمننت نبوده، چیزی بوده که انتخاب کردیم خود ما که فاندینگ ممبرها بودیم و دورمون به زودی تموم میشه. من که پرزیدنت بودم دیگه دورم تموم میشه و ما برای انتخابات بورد آینده ما از شما خواهش میکنیم که به این صورت دقت میکنیم. طبق بایلا وقتی که پرزیدنت میره کنار، تنها جابی که احتیاج به انتخاب نداره وایس پرزیدنته که وایس پرزیدنت در این دوران تجربه کافی پیدا کرده. البته دکتر سعیدی با تجربه بودن ولی ما با هم خیلی به اصطلاح همکاری شدید داشتیم و دکتر سعیدی تنها پوزیشنی است که خواهد بود بقیه پوزیشن ها که وایس پرزیدنت باشه، تریجرر باشه، سکرتری باشه، ممبر ات لارج باشه و کمیته های مختلف، کمیته ممبرشیپ، کمیته به اصطلاح تریجری، کمیته های مختلف، منتورشیپ، تمام اینا احتیاج به ما والنتیر داریم که برای انتخابات ما اینا رو اعلام خواهیم کرد که این پوزیشن ها خالیه. هر کسی که دلش میخواد برای این پوزیشن ها خودشو داوطلب بکنه. ما تا آخر نوامبر وقت میدیم که تمام کسایی که بخوان به اصطلاح والنتیر بشن اعلام بکنن. فقط من از کسانی دوست دارم که والنتیر بشن که واقعا باید کار بکنن، چون اینی که شما الان دارین میبینین نتیجه این همه زحمت بوده، واقعا کار کردن یه روی. اگه کسی فقط بخواد اسمش باشه اونجا و کاری نکنه، بهتره که نه. از اول من براتون آدم خیلی رو راستی هستم، حرفا رو سریع میزنم. کسی که بخواد کار نکنه لازم نیست که والنتیر بشه، ولی اگه واقعا دوست دارید که والنتیر بشین، ما خیلی خوشحال میشیم و خیلی مقدم بهتون میگیم و این ریزالتش رو در اوایل دسامبر اعلام خواهیم کرد. همونطور که داریم میبینین ما خیلی سعی میکنیم که شفاف باشیم، همه کارامون مشخص باشه، هیچ چیزی به بسیار زیر میز نخواهد بود. ممبرشیپمون امیدواریم که شمایی که ممبر هستین به بقیه دوستانم، چون این مسئله است که واقعا ماست و ماست هستش. اگه دوست دارین این ارگانیزیشن رو به دوستانتون بگین کمک کنن. خوشبختانه کسانی که پزشک هستن سالی $250 دادن ممبرشیپ رقمی نخواهد براشون، بنابراین از نظر مالی هاردشیپ به وجود نخواهد اومد، ولی ارگانیزیشن ما رو قوی میکنه که ما بتونیم این کارا رو انجام بدیم. علت که ما امسال ویرچوال کردیم برای نداشتن امکانات کافی مالی بود و ما دوست داریم این بسیار این پرسن باشه. میدونید که وقتی که میتینگ این پرسن هستش اثر بسیار بسیار زیاد داره. نتورکینگ با هم از هم آشنا میشن و خیلی خیلی بهتر هستش و چند روزی با هم، 2 روز لااقل با هم زندگی میکنن و خیلی بسیار از هم یاد میگیرن و شیر میکنن افکارشون رو. بنابراین امیدوارم برای آینده از والنترامون هم که واقعا همیشه ساپورتر ما بودن، البته نخواستن من اسمشون اعلام کنم و من واقعا دوست دارم، ولی اسمشون اعلام نکنیم. این والنتیرامون براشون نامه تشکر همونطور که دکتر شوکو امیری گفتن فرستادیم براشون و ارگانیزیشن ما روی والنترامون و دونرامون و ممبرشیپمون میگرده و اینو بدونین که هر ارگانیزیشنی که قدرت مالی داشته باشه میتونه ادامه بده. نداشتن قدرت مالی چیز جالبی نیست. ما امیدواریم که امسال که گفتیم الان $14,000 داریم، سال آینده بگیم $34,000 داریم، $44,000 داریم و این با همت شما خواهد بود و من امیدوارم هیچ کسی دریغ نکنه در کانتریبیوشن به اصطلاح به قسمت مالی پاما که بتونه کارشو در آینده برای شما و آیندگان که از ایران تصمیم دارن بیان به اون هدفی که ماها رسیدیم اونا هم دلشون میخواد برسن. همه این البته نمیگیم که بیان برای همیشه بمونن، بیان اون چیزی که لازمه یاد بگیرن و برگردن ایران. امیدوارم به زودی برگردیم ایران همگی و اینو ادامه بدیم. من سخنانم همینجا پایان میپذیرم. اگر کسی سوالی داره بفرمایید.
مرسی دکتر شوکو امیری. اگر کسی از دوستان شرکت کنندگان در برنامه کامنتی، پیشنهادی، ساجشنی و یا حتی انتقادی دارن میتونن بفرمایند و من در ادامه صحبت‌های دکتر حسین میتونم بگم که از الان تا چند ماه دیگه، تا ماه نوامبر دسامبر، هر گونه پیشنهادی دارید برای اینکه چگونه این انجمن رو ما کنیم و یا شما رو همراه با انتقاداتتون، حتی اگر انتقادات تند باشه، برای ما بفرستید. ما حتما مرور میکنیم و به صراحت در نظر خواهیم گرفت. ارتباط مستقیم با ممبرها بسیار بسیار مهم هستش و به همین خاطر از تمام دوستان، ممبرها، اعضا و کسایی که ما رو ساپورت میکنن خواهش میکنیم که با ما در تماس بیشتر برای ارائه نقطه نظریات باشن. مرسی. من
تا دسامبر که اعلام بکنیم بورد جدید رو در خدمتتون خواهم بود و از اون روز به بعد دکتر سعیدی پرزیدنت خواهم بود و من آردی بهشون تبریک میگم و مطمئن باشین که یک پرزیدنت بسیار بسیار خوب و با قدرتی هستن و امیدوارم که به لول بالاتری این ارگانیزیشن رو برسونن. من به عنوان پس پرزیدنت در خدمتتون خواهم بود، ولی رول اصلی به دست شما جوونا خواهد بود.
منتظر هستیم که اگر از دوستان شرکت کننده کسی نظری، پیشنهادی، انتقاد داره بفرمایید.
واقعا ما مشتاقیم اگه انتقادی هم دارین که انتقاد باشه که ما بتونیم انجامش بدیم. معلوم نیست که همه انتقادات رو ما بتونیم انجام بدیم، ولی در حدی که ما بتونیم انجام بدیم باور بکنین که انجام خواهیم داد. ما عاشق این کاری هستیم که داریم انجام میدیم و هر کاری از دستمون بر بیاد انجام خواهیم داد. به نظر میرسه که ممبرشیپ خوشحالن از اون چی که تا حالا داشتن و امیدوارم که به نامینیشن های خوبی داشته باشیم که برای این به اصطلاح سمت هایی که خالی هست. باز تکرار میکنم: وایس پرزیدنت، تریجرر، ممبرشیپ، به نامینیشن کامیتی، بعد منتورشیپ کامیتی، تمام اینا اعلام خواهیم کرد. خودتون رو آماده بکنین برای این پوزیشن ها، اسماتون رو بفرستین، ما اعلام خواهیم کرد که کی چه سمتی رو در اوایل دسامبر خواهد داشت.
و سوشیال مدیا کامیتی که خیلی خیلی مهم است برای تبلیغات و مارکتینگ، اون خیلی مهم هستش که ما بتونیم با تکنولوژی جدید در امور اینترنت و مسائل مشابه بتونیم بریم جلو و پاینیر باشیم.
تشکر مخصوص من دارم از سوشال میدیا کامیتی که واقعا زحمت کشیدن و دیدین که این برنامه 2 روزه ما چقدر به خوبی پیشرفت کرد بدون هیچ. ما تجربه داریم که خیلی اشکال پیش میاد تو این برنامه. خیلی خوب پیشرفت. از همه شما، از کاترین جان، از متین جان تشکر فراوان میکنیم که این برنامه رو به این خوبی اجرا کردین. خیلی خیلی سپاسگزارم.
مرسی. خب به نظر میاد که
باید خداحافظی
سوالی کامنت بله دیگه، زمان خداحافظی هستش و به اصطلاح من هم از طرف خودم و گروه خداحافظی میکنم. تشکر میکنم از همگی شما، دکتر حسین شکوه‌امیری، دکتر سعیدی، دکتر معلم و دکتر کاترین شکوه‌امیری و بقیه دوستان که در این برنامه بودن و از بقیه فاندرها، خانم دکتر شفا امیرسلطانی و آقای دکتر امید آشوری که دکتر شفا امروز چند ساعتی رو بودن ولی به علت میتینگ دیگری نتونستن ادامه داشته باشن. در هر حال از همگی تشکر، خسته نباشید و به امید کنفرانس بعدی سال دیگه در همین حوالی ماه سپتامبر و در این مدت تلاشتون رو بکنید که اعضای بیشتری رو بیاریم و فعالیتامون رو بیشتر کنیم. خیلی خیلی متشکر، ممنون و خداحافظ همگی.
خداحافظ همگی.
خداحافظ همگی.
خداحافظ شما. خداحافظ.